Hello friends, now we'll start our area or section of diseases. Now before starting actual diseases, first we will be talking about some terminology which is very commonly asked from us in the examination and are also helpful in understanding the various diseases. Now who are the index cases? The index cases are first reported cases. It could be either primary or secondary case. Now who are the primary cases? Primary cases means the first case of the disease in the community, it is called as a primary case, and the cases which are developing coming in contact of the primary case, they are secondary cases. Okay, then the question is asked, who are the definitive hosts where the sexual cycle of an organism is undergoing. Like in malaria, mosquito, it is supposed to be the definitive host. In echinococcus, the dog is supposed to be the definitive host. And they ask about the various duration of periods. The time interval between entry of the organism and appearance of the first sign and symptom of the disease is incubation period. Time interval between entry to maximum infectivity of the disease is generation time, and time interval between entry to 50% of the cases to develop is median incubation period. So wherever the 50% cases, it is the median incubation period. Time interval between the primary and the secondary case, because the new cases are developing in the series, so it is serial interval. Then how long we are separating a healthy exposed till maximum incubation period, it is called as quarantine. Now all these periods are directly or indirectly related to incubation period, except the one period which has no connection with incubation period, that is period of communicability. It is during which we are separating the deceased person, that is what is the isolation. Okay, so separation of the deceased person till a period of communicability, it is isolation, and period of communicability means that how long or during which period the disease can be transferred from one to another. It is infectious, it is period of communicability, and during that period we are isolating the diseased individuals. Then organism in the vector undergoes either the mechanical cycle or biological cycle. Mechanical cycle means there is no change in number as well as there is no maturation, simply lifting the organism from the one place and dropping to another. Like a housefly, it is dropping organism from one to another. But if organism in the vector undergoing the changes, it is biological cycle. Now changes, what it can happen, either it is increasing in the number only, and that is what is called as, it is the propagative cycle. Propagative cycle, there is only increase in the number, maturation doesn't happen, and this is commonly seen for the plague bacilli in red flea, okay, or as well as it is also seen for dengue virus in Aedes mosquito. Now what is the cyclo-developmental? When cycle is undergoing the development or maturation, so only the maturation of the cycle goes on, the number remains same. This is in Culex mosquito for microfilarias. But when both the action happens, there is increase in the number also as well as the maturation also. This is called as cyclopropagative, and this is seen for malaria parasite in Anopheles mosquito. So these are the different type of biological cycle. So we should be knowing what happens to do that cycle and in which vector this cycle is going on. Two rates are asked, is one is the case fatality rate. It is telling us about the severity of the disease or the killing power of the disease, okay, but it doesn't tell us about infectivity, means if a one person is having the disease, how many who are coming in contact will be infected. It is not given by the case fatality rate. So it is given by the secondary attack rate, that is the infectivity of the disease. So infectivity of the disease is given by secondary attack rate, and the severity of the disease or the killing power of the disease, it is by case fatality rate. Now case fatality rate means the total deaths because of that particular disease out of 100 cases, okay, or we can say the total deaths because of the disease divided by the total cases of the disease into 100. So remember, here in the denominator we had a total cases. Now if in the denominator we had a total deaths, and out of the total deaths how many deaths are happening because of that disease, then it becomes a proportional mortality. So be very careful. अगर denominator में total deaths है, then it becomes a proportional mortality. अगर denominator में total cases है and out of that how many deaths are happening, it becomes a case fatality rate. Now, for calculating the secondary attack rate, we should be knowing how many are the secondary cases. We know the secondary cases means the cases who are developing from the primary case, but it is taken in only the single incubation period divided by the total susceptible. That is important, and to calculate the total susceptibles, always we have to exclude the vaccinated children in the community, as well as we have to exclude the primary case because that is the first case, and after infection that become immune. Okay, then remaining individuals are the susceptibles, and out of that susceptible, how many are developing a disease in a single incubation period, that is secondary attack rate. We should be knowing the incubation period and period of communicability for some important diseases, and these two diseases are very important, that is measles and chickenpox. So, measles ka incubation period is 10 to 14 days, single answer is day 10, and period of communicability is 4 days before the rash to 4 days after the rash. And for chickenpox, period of communicability is 2 days before the rash to 5 days after the rash, and incubation period is 14 to 16 days. Then reservoir, it is not only the live organism, it is a non-living organism also, like soil is acting as a reservoir for tetanus and the fungal spores, as well as the living organism may be the animal or humans. It is not always that if a disease is present, infection is present, they will be showing the signs and symptoms. Now, if a infection organism are present and without any infection, means if the organism has not invaded inside the cell, they are simply called as the carriers. But if the organism is present, it has invaded the cell also causing the infection, then again these are called as the cases. It could be with clinical symptoms, which are called as the clinical cases. Without the clinical symptoms, they are called as subclinical cases. Okay, so in our single disease cycle, we can have the subclinical cases, clinical cases, as well as the carriers also. So this is about the basic point. Now coming to our first group is vector-borne diseases. It is your very important image-based question of this program logo, and the first question, that which diseases are included under this program. The 6 important diseases are included, that is 5 with the cause because of the mosquito, like malaria, filariasis, Japanese encephalitis, dengue, chikungunya, and the one this is caused by the sand fly, that is leishmaniasis, but it is not including yellow fever because yellow fever disease is not seen in India. So, we are not going to control this. Now, for malaria, the important point is that vector is Anopheles, female Anopheles, biological cycle is cyclopropagative, the mosquito it is the definitive host, and if the mosquito is giving the bite, then sporocytes are entering and relapse possibility is seen. But if it is a blood transfusion induced malaria, then trophocyte form is entering, then there is no possibility of the relapse because this pre-erythrocytic phase or the liver the hepatic phase, it is absent if it is entry is through the infected blood transfusion. Okay, but if it is through the mosquito bite, then the hepatic cycle goes on and there is always a risk of relapse. Okay, and that's why this is the site where the vaccine they work, they prevent the entry of these sporocytes into liver and they block this entry, and that's why the malaria is prevented. And that's why the 5 tests we are doing before blood transfusion in donor, that is for HIV 1 and 2, hepatitis B, hepatitis C, malaria and syphilis, to prevent the recipient from having these infections. The best test for the diagnosis of malaria is peripheral blood smear examination. Okay, and here we are preparing the 2 smears. The thickest smear is for the diagnosis of malaria and thinnest to know the species or the type of malaria, because treatment is based on the species. These slides are prepared by multi-purpose worker male, either in the sub-center or in village also at the part of active surveillance, but the slides are checked at PSC primary health centers and we should be getting the report within 24 hours. Now, if PSC is far away or because of any reason, if we are not getting this peripheral blood smear report within 24 hours, then we are going with the rapid diagnostic test kit use, and this test can be performed by ASHA also in the periphery. And here we are checking for two proteins in malaria antigen, or it is or the plasmodium agent, that is histidine rich protein and LDH. Now, if we further go in the detail, now HRP, histidine rich protein, it is highly sensitive, but only the drawback is that it is remaining positive for a longer time even after the treatment. But LDH, it is more specific. It is more specific for especially for the falciparum, and the same is HRP is also for highly sensitive for the falciparum, but for other malaria proteins also. But advantage for this LDH is it is clearing quickly after treatment, so it is more specific. But nowadays in most of the kits we are having both the proteins, the dual protein we are checking up, that is histidine rich protein and LDH, and the purpose is that we are detecting each and every case of malaria, and there should not be any false positive cases also. Now, once the patient is diagnosed with malaria, then we have to look for whether the female patient the patient is pregnant or not. Second is what is the species of malaria, and the third one is that if it is the falciparum malaria, whether the patient belongs to the northeast states or other states. Now, if it is a Vivax infection, obviously in the non-pregnant or in the general population, then in all the states the drug of choice is chloroquine with primaquine. अगर single based answer देना है तो chloroquine, because primaquine we are giving to prevent relapse cases. The dose of chloroquine, try to remember, 25 milligram per kg the body weight in the 3 divided doses, and primaquine we are adding just 1/10 of this to or rather 1/100 of this 25 milligram is the chloroquine, and 0.25 milligram per kg of the body weight per day, it is the primaquine. But primaquine is given for 40 days and chloroquine it is only given for 3 days. Now, if it is a falciparum infection, then in the northeast states we are giving artemether lumefantrine combination, and artemether lumefantrine it is given daily for 3 days, and on the day 2 we are adding single dose of primaquine. It is 3 times of the dose of Vivax infection, that is 0.75 milligram per kg of the body weight. But if a patient is coming from the other states, then we are having the artesunate sulfadoxine pyrimethamine combination, ACTSP. Artesunate it is given daily for the 3 days, then day 1 pe we are adding the single dose of sulfadoxine pyrimethamine, and day 2 we are adding the single dose of primaquine, same as 0.75 milligram per kg of the body weight. Then if a patient is pregnant, in that case, if it is a Vivax infection, patient is coming in from any of the state and in any of the trimester, the drug of choice is only chloroquine. Primaquine is contraindicated in pregnancy, okay. But if it is a falciparum infection, then in the first trimester in all the state, the drug of choice is now quinine with clindamycin. Quinine with clindamycin, and this is as per the Indian Government of India guidelines, and WHO says that artemisinin group of the drugs are also safe in first trimester. So, we can also give this ACT-ASP or ACT-AL, but it is as per the WHO. But if a question is asked in our exam, our answer should be the quinine with clindamycin, because we are appearing in Indian licensing exam. Okay. In the second and third trimester, depending upon the states, if it is from the northeast state, then it is ACT-AL combination. Other states may it is ACT-SP combination, and the same primaquine is contraindicated. Always remember, if a patient of any type of malaria, in any phase of the disease, if patient can take oral, prefer to give the oral treatment. But if a patient can't take oral, like patient is having some cerebral symptoms or the giddiness and the unconsciousness because of cerebral malaria, in that case injectable preparations are given. Then prophylaxis is again a very common area from where question is asked is, it depends upon the duration of the stay. If a patient is going to stay for less than 6 weeks, the drug of choice is doxycycline, okay, and going to stay for more than 6 weeks, then either mefloquine or chloroquine, any of these drugs are given, and in any of the situation, the drugs has to be continued for minimum 4 weeks of a patient of a person leaving that area, okay. But if patient is pregnant, then irrespective of the duration of the stay, the drug of choice is only chloroquine. The best indicator for active malaria transmission of in the malaria program is API, annual parasite incidence. But the best indicator of the recent malaria transmission is infant parasite rate. But if a question is asked which is an important indicator of the malaria program, is API, annual parasite incidence. It is the new malaria cases per 1000 population at risk per year in that area. What should be the minimum annual blood examination rate? It should be minimum 10% of the population. We are having the centers to distribute the drugs to confirmed cases of malaria in the village, that is drug distribution centers. If we are preparing the slides also in the village, and that this is called as fever treatment reports, 1 per 1 village, that is 1 per 1000 population. The national plan जो है गवर्नमेंट ऑफ इंडिया का, that is framework for malaria elimination, is that we have to eliminate the malaria by 2030, and at least we should be having the 3-year window of malaria free stage. So we should be having the zero new cases or zero API in all the districts by 2027. So this is as per the national strategic plan, is zero indigenous cases throughout the country by 2027. 3-year malaria free window, and that's why by 2030 we should be able to eliminate malaria. Okay, so 0 case by 2027. So we will be eliminating malaria by 2030. And how we can be eliminating? This is strategy. It is what the summary of the topic, that we have to do the active malaria surveillance by multipurpose worker male. Then if we had a suspicion of malaria, the strategy is test, treat and track. Test karna, treat karna and track karna from which area they are coming, looking for mosquitoes in that particular area. Now here, as the disease is spreading through a female Anopheles mosquito which is resting inside the house. So for mosquito control we are doing the indoor residual spray. Okay, like Culex ke liye in filariasis we are doing an outdoor fogging, but malaria ke liye we are doing indoor residual spray. Remember this point. Then vector control के लिए along with the indoor residual spray we are trying to target the larvas also, and anti-larva measure are applicable only in the urban areas. And how this malaria or the Anopheles mosquito larva, they are present in water. We know that Anopheles adult mosquito, it is sitting with an angle to the surface. Okay, it is sitting with an angle to the surface, and its larva, it is hanging parallel to the surface. So to kill the Anopheles larva, we have to put either the sprinkle Paris green dust or any oil, and this will be killing these larvae, or we can leave the Gambusia fishes. This we had discussed in detail in our topic of environment. In which area we are having the rural malaria scheme applicable, and in which area we are having the urban malaria scheme applicable? As the same guideline of the urban and rural health mission, if a population is 50,000 or more, we are having the guideline of the urban malaria scheme, and where we are having the rural malaria program or rural malaria scheme going on in the population of less than 50,000. Okay, so less than 50,000 we are having the rural malaria program, and for population of 50,000 or more we are having urban malaria program. And the malaria vaccines, as I told you, that they are blocking the entry of these sporozoites in a liver, so they are preventing the further spread. They are preventing the further spread. And recently a new vaccine has been developed by India itself, and that is for falciparum malaria. It is the Falcivax. Okay, and the other two were existing, which has been approved by WHO, that is RTSS, this is Mosquirix, and the Matrix M, okay, or R21. So this is all about our the first disease, that is malaria. Now if we go with some high heel points, not high heel, rather we can say there are some extra edge points are that for the falciparum we are having the different color coded kits are available as per the body weight. We are having the different number of the tablets. Adults may the weight is roughly considered as more than 35 kgs or more than 14-year person ke liye we are having the white color kit available. Okay, as for the both falciparum in the northeast states as well as the falciparum in the other than northeast states. So color kit is, that is a white color blister pack is there. Then second disease is filariasis. Here there is blockage of lymphatic system, so causing the swelling of these different parts. Then most important factor is the Culex, but it can be caused by Mensonian or the other mosquitoes also. Okay. Then biological cycle is cyclodevelopmental, and man is supposed to be the definitive host. The most dangerous period is asymptomatic microfilaria, when microfilarias are present in the circulation but patient is not having any symptom. The best test for the diagnosis is membrane filtration test, but peripheral test what we are doing is peripheral blood smear examination. In contrast to malaria, only the single thick smear is prepared because we have to see only the presence of microfilarias, and it is best to be prepared in the late evening hours between 8:30 p.m. till 12 midnight. Once the diagnosis is made, the drug of choice for treatment is ivermectin, diethylcarbamazine and albendazole IDA therapy. Ivermectin single dose 150 to 200 microgram per kg of the body weight, diethylcarbamazine 6 milligram per kg per day for 12 days, and albendazole 400 milligram single dose. All these three drugs are given oral, okay, and simultaneously is a supportive treatment we have to give. The goal is that we have to make India free from filariasis by 2027, and the criteria is that the number of the microfilaria carriers, means a person having microfilaria in the circulation should be less than 1%, and the children who are born after 2002, where the program was started, should not be having any microfilarias in their circulation. And the strategy is that we are doing the mass drug administration in the area where microfilaria is more than 1%. So what we do is, first we do the mapping, and if microfilaria means percent of the slides which is showing the microfilarias in the community, if it is more than 1%, in that case we are starting the mass drug therapy. Okay, and mass drug therapy or mass drug administration, it is with the same three drugs what we are using for the treatment IDA, but only the difference is that here in the treatment diethylcarbamazine is given for the 12 days, but in the mass drug administration all the three drugs are given once only, every 6 monthly. Okay, so single dose of ivermectin 150 to 200 microgram per kg, single dose of diethylcarbamazine 6 milligram per kg, single dose of albendazole 400 milligram, that is given twice in a year in the endemic areas. Okay, and continuously this we are giving for around 5 to 6 years, and again after 6 years we are doing the assessment, that is what is called as a TASS, that is transmission assessment survey, and if after 6 years we found that microfilaria now it is coming down to less than 1%, we stop MDA. But if we found that microfilaria still is more than 1%, then we will still continue for another 5 years. And for Culex mosquito, we are doing outdoor fogging because they are resting outside. Talking about the next disease as dengue fever, it is caused by the group B arbovirus spreading through a vector as the Aedes mosquito. Now, 4 strains are present for the dengue virus, V1, V2, V3 and V4, and against these 4 strains we are having the quadrivalent vaccines available. But one important point is, if a person has a first infection with the one strain, developing antibodies against that, it is not protecting the infection with another strain, rather the infection with another strain, it can flare up the symptoms leading to dengue hemorrhagic fever or shock syndrome. And the dangerous combination is, that is, if initially the V1 infection followed by V2, then these dangerous symptoms will be more seen. Okay, so next time the infection with the new strain, it is more dangerous. The best test for the diagnosis is RT-PCR, but first test what we are doing is detection of viral antigen by NS1 antigen test. Then supportive test we can also go for. Only treatment is supportive because it is a viral disease, it is settling on its own. The platelets are not transfused left and right. So, it is transfused only if there is a presence of any abnormal bleeding, abnormal coagulopathy, or the platelets are dropping to less than 10,000 without bleeding. Okay, but if it is more than 10,000, like 20, 30, 40 without any bleeding, then we are not transfusing platelets. When we can be giving the whole blood or RBC transfusion, if there is a loss of more than 10% of the blood volume is there, or in the presence of the refractory shock. but the main is the prevention of dengue, and we can have the primordial level prevention very easily possible, because Aedes mosquito, they are breeding in artificial water collection. So we can avoid the mosquito breeding by avoiding the artificial water collection, that is primordial level prevention. And simultaneously we are doing a mosquito control also. Quadrivalent live vaccine is available against the dengue, and it is two vaccines available in the market. One is Dengavaxia, another is Qdenga. The only difference between this is both are the quadrivalent, both are the live vaccines. The Dengavaxia were given only those who had a first infection with one strain, and this is only effective in a seropositive, means had a one strain infection, and it is preventing the secondary infection and its complications. But the Qdenga vaccine, it is effective in both seronegative and the seropositive, means it is effective in those who never had a dengue infection also, as well as who had a past infection with one strain. It is effective in both. Then we are now developing another method, is controlling the transovariant transmission of this virus. Transovariant transmission means the one adult Aedes mosquito is capable of transferring this dengue virus to the next generation. So we are trying to block this, and this is by Wolbachia method. And what is a Wolbachia method is? Wolbachia is a bacteria. So what we do is we are injecting this bacteria in the larvas and in eggs. So when they hatch into an adult mosquito, and this mosquito, it is born with this Wolbachia bacteria. Okay. Now if this mosquito, it is having the fertilization with another mosquito with the dengue virus, so whatever the eggs they are having, now if it is having the dengue virus as well as if it is having the Wolbachia bacteria, then it will not further grow. So whatever the bacteria, viruses, eggs are there, it will be destroyed there only. Okay. But suppose if before fertilization, if this mosquito which is having the dengue, this Wolbachia bacteria, if it is biting a dengue person which is having a dengue virus in the circulation, and suppose the dengue virus, it is entering into this mosquito. Okay. So it is possible, is it possible that before fertilization it can transfer the infection to others? No. So what is happening when this mosquito which is having the Wolbachia bacilli, if it is getting the Aedes virus from an infected person, so if it is trying to bite another healthy person, what will happen? That healthy person will not have the dengue virus, because this Wolbachia bacilli is blocking the dengue virus in this mosquito. So this healthy person will not have the dengue infection. So further it cannot spread the disease. So that's why we are blocking the transmission of the disease. So either in the fertilization the eggs will not mature, or even before fertilization, if it is biting another person, that person will not have the dengue, and that's why it is preventing the dengue infection. Then in this group, the next disease is the Chandipura virus encephalitis, which is giving the clinical manifestation like as an encephalitis, and it is spreading through female sand fly. Okay, it is spreading through female sand fly. So this is all about our first group as vector-borne diseases. The next important disease group is the zoonotic diseases, and the first important disease in this group is rabies. The rabies is a disease which is having 100% case fatality rate with 0 secondary attack rate, and all the wild animals are usually the reservoirs, and the saliva of a rabid animal is considered as a source because it is containing rabies virus. There is no role of herd immunity, means a vaccination of a one person is not going to protect another person. The rabies free countries are those which are surrounded with water, as like in Australia, New Zealand and other countries, and the rabies free states in India is states of Andaman Nicobar Islands and Lakshadweep. The diagnosis in the dead person or animal, It is done by demonstration of Niagara bodies in brain tissue, and the area from where the biopsy is taken in the brain, it is either hippocampus or cerebellum. If you have to do the diagnosis in a live person, we have to take a skin biopsy from nape of the neck and demonstrating viral antigen by fluorescence antibody test. What is the grade of the dog bite will deciding the action? If there is a lick on intact skin, it is grade 1. If there is a scratch or nibbling or depression but no blood, it is grade 2. But if there is a multiple lacerated wounds or any of the wound with bleeding, or there is a lick or splash on the mucosa, like it is on the lips or splash on eyes, then it is a grade 3. But always remember, in the immunocompromised individuals, if a patient is having HIV, now if it is a grade 2 wound, consider this or treat this wound as grade 3. Okay, so in HIV patients, a grade 1 will be treated like as a grade 1, the grade 3 will be treated like as a grade 3, but if it is a grade 2, then we have to treat like as a grade 3. Then what we are doing in this, or how we are managing this grade of the dog bite, the first grade 1 action, that is only the local wound care, or grade 2 actions, the local wound care plus vaccine, grade 3 actions, the local wound care, vaccine and immunoglobulins. Now what we are supposed to be in the local care? The local care may we have to clean the wound with running water for minimum 15 minutes, apply the antibiotic or local antibiotic like povidone iodine. If it is a lacerated wound, muscle is hanging down or massive laceration is there, if you have to put the stitches, don't put the stitch for at least 24 hours. Okay, and because with the needle and thread you can make virus to enter into circulation quickly. Now, if it is a grade 3 wound and if you have to give the immunoglobulins, then immunoglobulins is given locally at the site of the wound. It is never given parenterally or intramuscular or IV. Now, how much is the immunoglobulin? Depending upon we are using a human or animal. Human is 20 international unit per kg of the body weight. Animal is 40 international unit per kg of the body weight. But be very careful that first assess the wounds. Okay, and whatever is the total dose. If wounds number is more, then you have to dilute the total dose in a distilled water, and then equally you have to divide in all the wounds. ऐसा नहीं है कि in only one wound you are giving the total dose. No, equally you have to divide this immunoglobulin in all the wounds. ठीक है. Another important point is that immunoglobulin is only given once in the lifetime. Like if a patient has received the previous immunoglobulin in the past, or if he had previously received the rabies vaccination. Rabies vaccination may be prophylactically or following a dog bite, and after that if a reinfection happens, then we are never giving the immunoglobulins even if it is a grade 3 bite. ध्यान रखना, ठीक है. मैं हिंदी में भी बोल रही हूँ कि इम्यूनोग्लोबुलिन क्या है कि हम लाइफ में एक ही बार पेशेंट को देते हैं. अगर माना क्वेश्चन आता है कि उसने पहले उसको ग्रेड 3 बाइट हुआ था और तब उसको पूरा कोर्स मिला वैक्सीन इम्यूनोग्लोबुलिन, फिर से उसको 10 साल के बाद में ग्रेड 3 बाइट हुआ है, तो हम उसको खाली वैक्सीन देंगे, इम्यूनोग्लोबुलिन नहीं देंगे. ठीक है. या अगर उसको पहले ग्रेड 2 बाइट भी हुआ है और उसको फुल डोज ऑफ इम्यूनोग्लोबुलिन मिला है और दोबारा से रीबाइट हुआ है, चाहे वो ग्रेड 3 बाइट भी है, तो भी हम उसको खाली वैक्सीन ही देंगे, इम्यूनोग्लोबुलिन नहीं देंगे, क्योंकि पहले एक्सपोजर के बाद में कुछ इम्यूनोग्लोबुलिन स्मॉलर अमाउंट में सर्कुलेशन में पड़ा रहता है. ठीक है. तो वो क्रॉस रिएक्शन होकर दिक्कत करता है. सो इफ अ इम्यूनोग्लोबुलिन प्रीवियसली रिसीव द रेबीज प्रोफाइलैक्सिस, ठीक है, देन इन द केसेस ऑफ री इन्फेक्शन only we are giving the vaccine, only give vaccine, okay, irrespective of the grade of the wound. ठीक है. तो या तो जो है प्रीवियस इम्यूनोग्लोबुलिन अगर मिला है तो दोबारा इम्यूनोग्लोबुलिन नहीं देंगे, और इवन अगर प्रीवियसली उसको रेबीज प्रोफाइलैक्सिस मिला है either as a pre-exposure or the post-exposure, then अगर re-infection हुआ है then only we are giving the vaccine irrespective of the grade of the wound. ठीक है. Now, schedule is very important. Before the dog bite, pre-exposure prophylaxis, 3 doses 0, 7, 21 or 28. It is given by intramuscular route. And the goal is to maintain the antibody titer of more than 0.5 international units per ml, and every 2 years we have to give the one booster dose. Post-exposure prophylaxis in this already vaccinated individuals. If they receive the vaccine within 3 months, then only the wound care, no vaccine is given. But if it is they had received within 3 months to the 2 years, then booster doses of the vaccine. The booster doses are the intramuscular or the intradermal day 0 and day 3. It has no connection with the dog bite. It is when we are starting, and that is what is the day 0 and the day 3. Okay? And if you have to choose between these two, the intradermal is preferred than the intramuscular because it is having the better antibody production and the lesser doses are required, and the intradermal dose is around 1/5 of intramuscular. Like intramuscular we are 0.5 ml use karenge, so intradermal it will be only 0.1 ml. If it is beyond 2 years the vaccination was given, in that case the full vaccine schedule you have to give. The full vaccine, either if it is a reinfection or after 2 years of the previous vaccination, or in a non-vaccinated individuals, we have to give the full schedule. If it is the intramuscular route we are giving, then we follow the SN regime. SN is a 5-letter word, so 5 doses, 0, 3, 7, 14 and 28. Thai Red Cross, 4-letter word, it's a 4 doses by intradermal route. Schedule is written as 22220 as 22202. This is the site, means at a day 0 we are giving on the 2 sites, that is the 2 deltoids. Then day 3 again the 2 sites, day 7 again on the 2 side, day 14 we are not giving any a vaccine, and day 28 we are again giving on the 2 site. Now, there is another regime is the Jarab regime. Jarab regime is intramuscular. It is written as 20101. It is number of the ampules what we are giving. On the day 0, we are giving the 2 ampules. The day 3, we are giving the no ampule. Day 7, again the 1 ampule, and again the day 28, 1 ampule we are giving. So, this is how we are giving the vaccine prophylaxis. Japanese encephalitis is a disease which is spreading through the bite of Culex mosquito caused by the group B arbovirus, presenting the symptoms of encephalitis, and this Culex mosquito they are breeding in dirty water. Okay, so this is a disease which is related to areas where we are having a rice paddy fields are there, because in the rice paddy fields we are having dirty water collected. Now, this is the image of life cycle. Normally, it is between the bird mosquito cycle goes on, and sometimes if mosquitoes bite a human, then it is the dead end infection is there for the virus in human. And if the mosquitoes they bite the pigs may the virus amplifies, multiplies, and again this mosquito bite and suck these viruses. But pigs never shows the feature of encephalitis. So, role of pigs is it is act as an amplifier. Now, Culex is a night biter. So, daytime mein the Culex is requiring to hide themselves. Okay, so they are resting in between the hair of tail of cattle. So, cattle are acting as mosquito attractant. Pigs are amplifiers, but the cattle are mosquito attractant, and this disease is absolutely prevented by vaccination. And this JE vaccine we are using in our UIP program in the endemic states, not in all the states. And both the type of vaccines are available live and kill, but what we are preferring, the preferred vaccine in our national program is now the killed vaccine, and the Kula strain we are using. So, everything about the JE vaccine we should be knowing. As this Culex is resting outside, so we have to do outdoor fogging. Rickettsial disease ke liye we should be knowing the agent, vector, the drug of choice, and for the treatment and prophylaxis. The 3 important typhus fevers, the epidemic typhus, Rickettsia prowazaki number 1, like a primordial level prevention on the top. So, prowazaki, it is spreading through bite of louse. Endemic typhus, it is Rickettsia typhi, is spreading through the flea, and the scrub typhus is S is the scrub typhus, and Rickettsia susugamushi, it is the agent. And if we say this is as a sandwich layer of epidemic typhus, the top layer of the bread, and then scrub typhus is the bottom layer of the bread, and in between is stuffing, and stuffing क्या होता है, crush हो जाती है, reduce हो जाती है. So, it's a small letter name of this agent for endemic typhus is the Rickettsia typhi. Okay, and scrub typhus, it is spreading through bite of mite, and a special lesion is present, that is again starting with the having an S, that is the Ishar. It is crust, black color का crust है on the ulcer which is covered with the black crust, and this is ishar, it is diagnostic of scrub typhus. Okay, then another important rickettsial disease is Q fever. Now 2-3 points. Number 1, which is the vector for Q fever? The first answer should be the no vector because it is spreading through aerosol route, but if it is not there, then we can go with soft tick. Second is, which is a rickettsial disease which is not having any skin lesion? It is Q fever. Which is the rickettsial disease which doesn't require the any vector for its transmission? Is Q fever. And what is the causative agent? It is Coxiella burnetii. Don't confuse, it is not the Bartonella quintana. Don't confuse the Q fever is the quintana, because trench fever is also known as quintana fever, and for that agent is Bartonella quintain. Okay, and the vector for trench fever is louse. The drug of choice for treatment of both rickettsial diseases and as well as its prophylaxis is doxycycline. Then we are having next disease is a yellow fever. Now yellow fever is a disease which is not seen in India, but we are yellow fever receptive zone, means we are having Aedes mosquitoes, we don't have a virus. Okay, so we are trying our level best to prevent the entry of these virus in India by following the quarantine guidelines. Okay, and we had already talked about that any person who is entering from endemic areas, like especially from African countries in India, we are looking for the yellow fever vaccination certificate. Okay, and if it is not there, then we are keeping the person in quarantine for a minimum 6 days. Okay, now this is the disease which is causing jaundice, that is yellowish discoloration of the eyes, severe body ache, headache, and severe high grade fever, and might be having the bleeding like as a dengue fever, because it is having a same virus as group V arbovirus. So it is very well prevented by avoiding its breeding, by avoiding the artificial water collection, by taking the vaccination, or using the mosquito nets, or having this full sleeves clothes are there. Okay, so yellow fever, the important points we have to remember is that is vector is Aedes mosquito, then incubation period is 2 to 6 days, that's why the quarantine for yellow fever is 6 days. Okay, the vaccine is available for yellow fever, and that is live vaccine which is having 17D as a strain given by subcutaneous route. And there is a strategy to control or prevent this yellow fever is a I strategy, that is elimination of yellow fever epidemic. Okay, and another disease is plague, which is spreading through the bite of red flea. So the vector for plague is red flea, but there is a one variety of plague when organism is reaching to the lungs, then it is spreading through aerosol route. So if a question is asked what is the vector for the pneumonic plague, then answer should be the no vector, because it is spreading through aerosol route. The incubation period is called to be as for plague 2 to 7 days, but if it is asked for the pneumonic plague, it is very short as 1 to 3 days. Nowadays we are not having quarantine for plague, but in the 14th century we used to have quarantine for plague for about 40 days, 40. Okay, the most dangerous type of the plague is pneumonic, because once you control your red flea, still the disease can be transmitted through the aerosol route. Most common is bubonic. The drug of choice for a treatment is giving the streptomycin, but if there is any plague cases are happening in the community, we have to give the chemoprophylaxis to the healthy community, and tetracycline it is used as chemoprophylaxis. Now simultaneously, along with the treating the patients, giving a chemoprophylaxis, we have to kill the red flea also by insecticidal agents. Okay, and red flea may we have to just spray the insecticidal agents and bringing down the red flea index to 0. Red flea index means that per rat पे कितनी red flea है. So it should be 0, means no red flea should be present on rat. It should all be destroyed within 48 hours. The important quality of the red flea is that they only hop. ठीक है, खाली जो उड़ती नहीं है, jump मारती हैं. ठीक है, and they can only jump till up to 4 inch above the ग्राउंड लेवल, ठीक है। तो आपको जब इंसेक्टिसाइडल स्प्रे करना है तो हवा में नहीं करना है, हवा में करेंगे सो इट विल ऑफ नो यूज, इट इज ओनली टिल द 1 feet height above the ground surface, then only it will be destroying all red fleas, ठीक है। So we are only doing the spray till 1 feet height, number 1. Second, the red fleas are still responding to the DDT, so we are using the first chemical as a spray is the DDT. If it is not responding, then we can use the malathion, otherwise the preference is given to DDT only. Then coming to another disease is leishmaniasis. It is again important because we are trying to have elimination of the disease. It is through a bite of sand fly. Normally the sand fly wild animal cycle goes on, but if it is biting human, then human sand fly cycle goes on, and it is leading to the blackish discoloration of the skin, high grade fever, cachexic look is there, there is a hepatosplenomegaly, so abdominal enlargement is there, and it is seen in the endemic areas like a state of Uttar Pradesh, Bihar, West Bengal, Karnataka. So the question says that a patient is coming from these areas, and if it is an advanced stage, we can have a skin nodules which are rupturing, and this is visceral, this is post Kala-Azar dermal leishmaniasis, okay. So the question is that what is the vector for leishmaniasis? It is the phlebotomous fly or sand fly. Then different forms can be there. The visceral leishmaniasis is Kala-Azar, it is also known as. Then cutaneous leishmaniasis, it is also known as the oriental sore, okay. Now this disease, it is supposed to be a disease of plain area, because sand fly, again they cannot fly beyond the 6 feet height. So this disease is only seen up to the 2000 feet or 600 meter above the sea level, only to that area only, not in the hilly areas, okay. And if we talk about the reservoirs, it is wild animals, but the visceral leishmaniasis may or Kala-Azar may, it is only the sand fly men cycle goes on. So the Kala-Azar or visceral leishmaniasis, it is supposed to be non-zoonotic, okay, and man is supposed to be reservoir in Kala-Azar, okay. Now peripheral test, what we are doing is, so basically it's a main worker for this active surveillance of leishmaniasis is ASHA worker. So ASHA worker क्या करता है? ASHA worker जो है is going every 3 monthly trying to find out the suspected Kala-Azar or leishmaniasis cases into the community, and this is what is called as a quarterly search, and every quarterly search में she is continuously searching for 15 days. So it's a quarterly fortnight survey, and any patient, if she comes across having a fever with the black discoloration, abdominal distension, cachexic look, she checks the antibodies against these leishmaniae in urine, okay, and this is what is called as RK39 dipstick test, ठीक है. Earlier we were doing in blood, but now it is comfortable to be performed in urine, ठीक है. So here they are detecting the antibodies, and it is done by ASHA worker in the periphery. If it is positive, then this patient is referred to the PSC for further confirmation, ठीक है. So confirmation क्या है PSC पे? Then we are demonstrating the LD bodies. LD bodies means we take an aspirate either from the liver or the bone marrow, or if there is a skin nodule from that, and we are demonstrating the protozoa, that is leishmania. And in this in human beings, these organisms, that is leishmaniae, it is not having its flagella, and this form is called as amestigote form or non-flagellar form. And this was a question that human may, it is losing its flagella, so amestigote form is seen, while in sand fly the flagella, it is present in these organisms, so it is promastigote form is there. To see for the immunity, we are going for intradermal test, that is leishmanian test. It is for immunity or the prognosis, but it is not for the diagnosis. Once the diagnosis is made, the drug of choice is LAMP therapy, liposomal amphotericin B, but it is given by IV infusion, and the dose is 10 mg per kg the body weight, single IV infusion. So we have to hospitalize the patient, and then we have to give the transfusion of this drug Okay, so if a question is asked what is the drug of choice for visceral leishmaniasis, it is lamb therapy. But अगर post कालाजार dermal leishmaniasis है तो we have to give a multiple repeated IV infusions, that is not practically possible. So it is an oral drug, that is miltefosine can be used, and simultaneously we have to do the vector control, and it is responding to the DGT. If it is resistant, then we can be using the BSC, and it is only spreading up to 6 feet above the surface level, because it is not flying to a higher level, and as DDT it is a residual and synthetic compound. So every 6 monthly or twice in a year we are doing spray, and goal is elimination of the disease by 2027, and criteria is that incidence should be brought to less than 1 per 10,000 population in the community, and ASHA is the main worker of active surveillance. Now, if we talk about the disease as leptospirosis, so this is very important, your image based question. Whenever you find rats, any water bodies and the human coming in contact of that, it is leptospirosis. So what happens? The rat urine, it is passing the leptospira, it is mixing with blood, this water, and whenever this infected water, it is coming in contact of any of the mucosal lining like an eyes, oral cavity or any of the wound, then these leptospiras, they enter into the human body and causing the disease leptospirosis. Another condition is the brucellosis. The brucellosis, it is related to domestic animals, not the wild animals. So these bacilli, they are passed in milk. Okay, they are in the milk. So if a person it is drinking the non pasteurized milk, or if a farmer who is having any cut wound, okay, if it is conducting their delivery or dealing with their blood, urine or feces, then these bacilli can also enter into the circulation and causing the brucellosis. So brucellosis is a disease with a low grade fever and lasting for a very long time, and it is included as group B bioterrorism agents. So if we talk these three diseases parallel, the vector for the KFD, Casanur forest disease, is also known as monkey disease. Outside India it is soft tick, but in India it is hard tick, which is also known as Haemaphysalis spinigera. Okay, but the source for leptospirosis is urine of the infected rat, as well as for brucellosis it is either the direct contact of the infected body tissues or the secretions of domestic animals, or by use of non-pasteurized milk. The reservoir is for the brucellosis domestic animals, for leptospirosis it is the rat, and monkeys are considered for KFD. Now, if we talk about the treatment, the doxycycline is the drug of choice for treatment of brucellosis, and for chemoprophylaxis of leptospirosis, we can be giving again doxycycline, as well as we are giving the live vaccine to prevent brucellosis to the farmers as well as to female cattle. Then the two diseases, two worm infestations related to animals, that is echinococcosis and the teniasis. This is again a very important image based question. The life cycle of echinococcosis, that is dogs are the definitive host, passing these in through the eggs and ovas in the stool. Coming through the food, it is entering into the sheep, and when sheep dies, its flesh is again being taken back by dogs. Accidentally, with the food, it is entering into the human body. So human is an accidental host in echinococcosis. In human being, it is leading to development of hydrated cyst. This is the first question, that hydrated cyst is seen in which disease? Echinococcosis. It is mainly affecting the liver and posterior superior lobe of right lobe of liver. Okay, and it is most commonly affected. Then another worm is teniasis. Normally, it is entering in the body through the intake of improperly cooked pork or the beef, and their muscle, it is containing the cysticerci. When these worms are in the intestine, it is the teniasis. When from the human intestine, they penetrate and reaching to the human muscle, it is the cysticercosis. And if it is reaching to brain, it is neurocysticercosis. So neurocysticercosis this could be an image along with the clinical question, and patient is presenting with all the symptoms of a space occupying lesion, and on CT and MR there is a space occupying lesion, but a fluid or the cystic area is seen inside. So this is neurocysticercosis. Okay, so definitive host in echinococcus is the dog, while it is intermediate host is sheep. But in teniasis, the man is supposed to be the definitive host, and intermediate host are pigs and cattle. The hydrated cyst is most commonly seen in the echinococcus. The organ affected is the liver, and that is posterior superior lobe of right lobe of liver is most affected. Nipah virus mein this image based question, it is very commonly asked as a life cycle of Nipah virus. Wherever in the image you find the fruit bats are there, the date palm sap is there, pigs and the contaminated fruits affecting the human, it is your Nipah virus infection. Okay, then it's a viral infection diagnosed by RT-PCR. It was very risky because having a 40 to 75% of the case fatality rate, and it was transmitted from one to another either by direct contact with the infected people or infected pigs or bats, or by consumption of the raw fruits which has been contaminated with the infected bat secretions or excretions. So this is all about our second group, that is zoonotic diseases. The next group is sexually transmitted diseases, and this is a important logo of the program, that is Red Ribbon National AIDS Control Program or Control Organization, and this is the logo for Suraksha clinics, where plus sign with the in the center, that is blood dot, red dot, that is again suggestive of a disease transmitted through blood or sexual route. Suraksha clinics are providing the services related to sexually transmitted infections. Here we are treating the patient based on the symptoms, that is syndromic approach. 8 color kits are there. Try to remember their number, color and purpose. Okay, so gray girl wearing beautiful red yellow big bracelet. So first kit, gray color kit, it is used for urethral symptom or the urethral discharge or the cervix discharge. Green color kit, it is kit number 2, it is used for vaginal symptoms of the discharge. Yellow color kit, kit number 6 for lower abdominal pain or PID underlying. The number 7 kit, black color kit, it is for B for black inguinal buboes, inflamed lymph nodes. Then brown color kit, kit number 8, it is for anorectal discharge. Now it has been separated. And for genital ulcers, if it is herpes ulcers which are red, tender, painful, red color kit is kit number 5 for herpes genital ulcers. If it is non-tender syphilitic ulcers, then white color kit for non-herpetic genital ulcers which are responding to the penicillin. Penicillin ka color hota hai powder ka white, so white color kit. Then if it is allergic to the penicillin and the genetic ulcers which are non-herpetic, then we are using the blue color kit, kit number 4. Now coming to which are considered as the high risk cases of HIV to whom we are doing screening: sex workers, transgenders, IV drug addicts, man having sex with man, these are considered as high risk. From the high risk, it is coming to bridge population, and who are the bridge population? That is long distance truck drivers, and single male migrant which are staying away from house, it is bridge population. So from the high risk, they are taking the infection. This bridge population is taking the infection from the high risk, and then from this bridge population it is going to the general population, means they are going back to their houses and spreading to their wives and other partners in the areas. Okay. Now, once any one of them is positive, we are trying to check for the close contact, and we are also doing the cluster testing, means testing the individuals who are moving in the same socio-sexual background, and this is what we are trying to find out. The hidden cases is known as sentinel surveillance. So, sentinel surveillance we follow in STDs or HIV. Now, if we talk about the HIV and the AIDS disease, here incubation period is a time required from an HIV infection to the AIDS development is around 10 years. The window period is, that is time interval between entry of the organism to appearance of the detectable antibodies is window period, and this is around 3 weeks to the 3 months time. So, if a patient has a recent infection, patient is within the 3 months of the recent infection window period, so we don't go for ELISA because ELISA may not be positive. In that case, you go with RT-PCR test is a number one test. If it is not in your choice, we can go with P24 antigen also. That's why if a mother has of a HIV positive who delivered a baby, and if you want to check the possibility of transmission from the mother to the baby, and 1 month old baby or 3 week old baby, we are only going for RT-PCR, not the ELISA. ELISA is only done after 6 months. ठीक है. So baby में जो टेस्टिंग करते हैं पहला 6 वीक्स पे करते हैं, दैट इज बाय द RT-PCR, एंड जो 6 मंथ का करते हैं दैट इज बाय ELISA. ठीक है. सो 6 वीक का वी आर नेवर डूइंग विद ELISA बिकॉज बेबी इज इन विंडो पीरियड. Now, there is a possibility of mother to child transmission without any treatment is 30%, okay, and breastfeeding is again 12 to 16%, there is a risk of transmission. So, earlier we were not allowing the mother of HIV patient to conceive because there is a 30% risk of transmission, but now with intervention the risk of transmission is drastically reduced. So, HIV positive mother can now become pregnant and she can deliver the HIV negative baby also. Then there is a risk of opportunistic infections. The most common opportunistic infection in India is tuberculosis, and most common opportunistic infection seen in the world is pneumocystis cerevisiae pneumonia, and this is seen only when the CD4 count drops less than 500. Okay, if it is more than 500, then usually opportunistic infection is not seen. The screening test, which is highly sensitive, is used as ELISA. Confirmatory test, which is highly specific, in India we are using the Western blot, but world mein or as per the WHO we are using RT-PCR, but India mein as per the government of India we are using Western blot for confirmation, which is highly specific. CD4 count and the CD4 percentage, means absolute count and the percentage of ratio of the CD4 to CD8. It is used as a predictor of HIV progression to AIDS. As the CD4 count reduces or its percentage count decreases, there is a higher possibility of conversion to AIDS. Okay. Then viral load, HIV viral load, it is suggestive of the response of a person to ART drugs. Okay, if responding to the ART, then a viral load count is reducing. Now, if we talk about the CD4 count and the CD4 percentage, the percentage is preferred over the CD4 count as a predictor of the progression of HIV infection to AIDS. Now, if we have to start the treatment, the best is that we should be starting on the same day of the diagnosis, that is called as a same day ART treatment, or we should be starting at least within 7 days, that is what is called as a rapid ART treatment. Now, if a person is HIV positive or the AIDS, then we have to give the drugs. The drugs what we are giving is called as heart therapy, that is highly active ART drugs are given. The first question, when to start? Now they say it has no connection with the CD4 count. Whatever is the CD4 count, 500, 600, 1000 plus, still we have to start the drugs as soon as possible. Okay? Earlier it was depending on the CD4 count, but now they say that there is no relation with CD4 count. So it has to be started as soon as possible on diagnosis. To whom we have to give? All the people who are living with HIV has a right to receive the ART treatment, and once it is started, it has to be lifelong. Now we are having the 3 drugs as a first line treatment, and it is remembered as a TLD protocol: tenofovir 300 milligram, lamivudine 300 milligram, and 50 milligram of dolutegravir. Now to increase the compliance, all the 3 drugs are available in a single tablet, and this is called as a FDC model. FDC means fixed dose combination therapy. So single tablet, it is having all the 3 drugs in this required doses, and patient has to take only the tablet once a day. Okay. So this FDC protocol, it is used in HIV as well as in the tuberculosis to increase the patient compliance. Now adult dose, if we talk about, adult dose means if a patient is having weight of 30 kg or more, as well as the age is 10 plus, then the dose is 1 tablet per day. It is given lifelong. If patient is not responding, then we can go with the second line. And how we can come? Patient is not responding, the viral load is not reducing, or the CD4 count is not increasing. Okay. The post-exposure prophylaxis, if a person has a sexual or parenteral exposure or surgical exposure with a suspected patient, in that case, we have to start immediately as soon as possible after the exposure, maximum within 72 hours. Best result ke liye within the 2 hours. We have to give the same drug, that is TLD, what we were using for the treatment, but here we are giving only for 4 weeks or 28 days. That's all. Okay? So once a day for the adult dose, like more than 30 kgs, more than 10 year plus, single tablet of TLD, that is once a day for 4 weeks. And we wait for another 2 months, and after 3 months we are going with ELISA, because once you cross the window period, then you are going for ELISA test. Now what is the PPT-CT? This is again a very important area. From here also the repeatedly question is asked that if any of the parents are positive, then there is a risk of the transmission of an infection to the baby. So it is prevention from parent to child transmission. Okay? Like if a mother is negative, but if still they want the pregnancy, so they are having a relationship and husband is positive, so husband is likely to transfer to mother, and from the mother it is going to baby. In that case, we are dealing with the 2 individuals, mother and the baby. Mother ko we are giving the treatment, and baby ko we are trying to prevent. So baby is having prophylaxis, primary treatment level prevention. Mother mate is a secondary level prevention. So there could be the 2 type of mother. One is who is a known case of HIV, taking the ART before the pregnancy, and then they become pregnant, and then they ask what to do with these drugs. So if a patient is a known case of HIV on the ART, don't stop. We have to continue the ART because it is safe in the pregnancy. Even in the first trimester, patient is to continue the drug. Okay. But if a patient is diagnosed for the first time during a routine antenatal screening and found to be positive, in that case again we have to start as soon as possible on the diagnosis. Even in the first trimester we can start. Okay. And it has to be taken throughout the pregnancy, delivery, breastfeeding, and lifelong. This is a part of the mother. Now newborn prophylaxis, we are trying to prevent the baby because the delivery make the chance of transmission from the mother to the baby is at the time of the delivery. So baby ke liye it is a primary level prevention. Now when we have to start the prophylaxis, again to the baby, within best is within 2 hours of the delivery, but maximum within 72 hours, or we can say as soon as possible. And this is the logo of PPT-CT, means red ribbon, it is across the husband, wife and the baby. So this is the logo of the component prevention from parents to child transmission. Now the question is, what drug to be given to the baby and how long? So this depends upon what is the maternal condition, whether the mother is taking any of the drug before delivery or not. Okay. Why? Because if a mother is taking the drug before the delivery, obviously its viral load should be less and there is a lesser chances of the transmission. But if a mother is not taking the drug at all, then there is a high viral load and there is a higher chances of transmission. So if a mother is taking the drug for a sufficient duration before the delivery. Now sufficient duration means at least must have taken 4 weeks before the delivery. In that case, we can say that is a good reduction in the viral count in mother. In that case, to the baby, only single drug, nevirapine, for 6 weeks irrespective of the breastfeeding, means either the baby is top feed or the baby is on a breastfeed, we are only giving for 6 weeks nevirapine. Second situation is either the mother is not taking any of the ART or has taken for insufficient duration, means just started 10 days before the delivery. In that case also the viral load is supposed to be very high, and mother is also called as a high risk case of transmission, and in that case the two drugs we are giving, nevirapine and azoravudine. How long? This depends upon the status of the feed of the baby. If the baby is top feed, then it is given only for the 6 weeks. But if a baby is on the breastfeed, then minimum 12 weeks we are giving. But as in India, we are having an exclusive breastfeed permitted to the HIV positive mothers. In that case, we are giving up to 6 months of the age. But if a question says that a patient has started at a few days before only, but a viral count is given, okay? Viral count is also deciding whether the mother is a low risk or the high risk. So low risk of transmission means agar viral load is, if we say the viral load is less than 1000 copies, agar viral load is less than 1000 copies hai, so that mother is a low risk mother. And which is called as a high risk of the transmission or the high risk mother is if the viral load is, more than 1000 copies. अगर viral load more than 1000 copies है, so that is a high risk mother है, उसमें हम 2 drugs देंगे. लेकिन अगर viral load less than 1000 copies है, low risk of transmission है, then only the single drug we are giving. ठीक है? So try to remember these two situations. High risk mother, the 2 drugs. Low risk mother, it is 1 drug to the baby, nevirapine 6 weeks, 2 drugs, nevirapine and the azoravudine. Breastfeed babies है, so minimum 12 weeks के लिए top feed babies है, so we are giving for 6 weeks. We are allowing the breastfeeding in the developing countries like India, but developed countries may they say it is contraindicated. And now here we are not having the supplementary feed, means only 6 months absolute breastfeed and then stop. So no mixing of the breastfeed and top feed is done. Then we are doing the follow at a rule of 6 weeks, 6 months, 12 months, 18 months, 6 weeks window period. So we are going for RT-PCR test, 6 month पे onwards we are going for ELISA. Final जो report है, it is at the 18 month पे, ठीक है? Now different activities are preventing the mother to child transmission to some extent. Without any treatment it was 30%, but if you are giving the ART to mother and the child both, newborn baby, then the final risk of transmission is less than 1%. Okay. Now the another point is, because the final diagnosis in the baby is at 18 months. So suppose if this baby will be an HIV, so there is a risk of opportunistic infections and baby prognosis will be poor. So we are giving the cotrimoxazole prophylaxis to all HIV exposed infants. To all HIV exposed infants, means their mother is positive, there is a risk that this baby is exposed. We don't know whether the baby is having HIV or not. So in all the babies who deliver to an HIV positive mother, we are starting the cotrimoxazole from the 6 week onwards, okay, till 18 month. And final diagnosis कब होना है बेबी का? 18 month पे. So final diagnosis अगर 18 month पे it is found to be positive, then still we have to continue till 5 years. Irrespective of the CD4 count, that is important, because adults में क्या होता है, depends upon the CD4 count, but children में 18 month पे it is positive, then we have to continue till 5 years irrespective of the CD4 count, okay. And after 5 years it depends upon the CD4 count. If it is more than 350 then stop, if it is less than 350 then you continue till it is increasing. But at the 18 month if the ELISA is negative, then we can be stopping. So what we can remember is prophylactic cotrimoxazole we are giving to all HIV exposed infants from the 6 weeks till 18 months till the final diagnosis is made. These HIV individuals are at a risk of having tuberculosis as a very common opportunistic infection. So, we are giving them the tuberculosis preventive therapy also. Okay? They don't have the tuberculosis right now, but we are giving them tuberculosis preventive therapy. Any of the protocol we are using, but preferred is that is for 3HP protocol. 3HP means the number is showing a month. So, 3 month ke liye we are giving weekly dose of isoniazid and rifampicin. So, once a week dose of isoniazid and rifampicin, and this is continued for 3 months. Okay? We can be using a daily dose also, but this is only for 1 month, and if we are having the daily isoniazid only, then it is to be given for 6 months. Okay? But preferred is 3 month duration of weekly isoniazid and rifampicin. Then we are having the classification of now the districts based on the prevalence of the HIV in high risk groups and antenatal cases. Now, district A, if it is prevalence is more than 5% in the high risk and more than 1% in the antenatal. The category B districts, when prevalence in high risk is more than 5% but antenatal less than 1%, and the category C districts, when in high risk less than 5%, in antenatal less than 1%, with some few hotspots are there, but if there is a no hotspots, then it is the category D type of districts are there. Very important infrastructure is at the level of district hospital level is ICTC centers in AIDS program, that is integrated counseling and testing centers. So, we are just doing counseling and testing of the patients here. If it is found to be positive, refer to the ART centers. They are again in the district hospitals, and here the first line ART drugs are given. After taking the drugs, the patient is coming back to their hometown, and for the follow up they are going to the link ART centers, which are at the level of the CSC, which is dealing with some minor problems. Like in follow up, if a patient is not responding to the drugs, then patient is referred to the ART plus centers, which are giving the second line ART treatment, and it is some selected medical colleges are acting as the ART plus treatment centers. Then we are having a very important national AIDS control program. It was started long back in 1987. And we are having the 5th phase of this program running now. Okay, 5th phase of this program running. And the current goal is that we have to reduce the annual new HIV infection and the AIDS related death by 80% by 2025-26. Baseline was 2010. So, whatever the new case infection rate and the death rate was in 2010, we have to reduce by 80%. As well as there should be the zero vertical transmission from the mother to the baby for HIV, and we have to eliminate the social stigmas or social discrimination of HIV or the AIDS related problem in the community. And we have to promote the universal access to quality STI services. So, these are the goals, and our targets are 95, 95, 95, and tuberculosis may be at 90, 90, 90. So, what this 95, 95 means, 95% of the patients should be knowing their status. Those who know that 95% of them should be treated with the drugs, and those who are on the treatment, the 95% should be having the good control of the viral load. The 95% population should be using the preventive methods. They should 95% should be having a facility for STD services. So, this is what is 95, 95, 95. Then global क्या है हमारा? We have to end the AIDS epidemic by 2030 globally. India में we had a special centers. One is the Sampurn Suraksha Kendra. Sampurn Suraksha Kendra means at a one place we are treating all the problems of HIV patients, and हाँ यहाँ पे हमारा जो goal है, the goal हमारा जो है that is the prevention test and treat strategy है. Like tuberculosis में we discuss, it is a we will be talking that is a test, treat and complete treatment है. And anemia में हमने discuss किया test, treat and talk है. Malaria में we discuss the test, treat and track है. And HIV में it is a prevention test and treat strategy है. We are having a special IST clinics. IST clinics means we are integrating the other diseases also. Like if a person is having HIV as a sexually related disease, so he is also at a risk of having the hepatitis B and C also, is having a risk of tuberculosis also as an opportunistic infection. So we are integrating the diagnosis of the syphilis, HIV, hepatitis B, hepatitis C and tuberculosis. So that is what is a same clinic we can be doing the diagnosis for all these conditions. Then now we had a diagnosis down at the level of the district hospital. This is called as a DISHA, District Integrated Strategy of HIV. So decentralized kiya from the medical colleges, now the diagnosis is going down to the district hospital level. Then we are promoting for use of barrier methods, male and female condoms in sex workers to prevent the transmission of infections. Then another important point is that if a patient is a case of tuberculosis, taking rifampicin based tuberculosis treatment, okay, and now has been diagnosed with HIV. So what we do is that if a rifampicin based ATT patient is taking, so we have to increase the dose for the HIV drugs. And HIV drugs में हम dose क्या use कर रहे हैं? TLD use कर रहे हैं, tenofovir, lamivudine and dolutegravir. So यहाँ पे you have to increase the dose of dolutegravir. So PLHIV, the people who are living with HIV are also taking the rifampicin based ATT. In that case, in addition to the single one tablet FDC of the tenofovir 300 milligram, lamivudine 300 and the dolutegravir 50 milligram, one additional dose of 50 milligram of the dolutegravir is added 12 hours after the regular dose, and this is continued till 2 weeks after completion of the ATT. This is the additional 50 milligram of dolutegravir we have to add up. Then post exposure prophylaxis, we had already talked about adult dose more than 30 kgs or more than 10 years. If you can remember for a smaller age group, it is fine. There is also the new concept is coming as the pre-exposure prophylaxis. Like as we had discussed in the rabies, professionally we are using a pre-exposure prophylaxis. Same is, we are also using a pre-exposure prophylaxis for HIV in non-HIV individuals who are at a higher risk of having the infections. Okay? And who are at a higher risk of having the infection, like suppose the female is HIV positive, and if they want to have their baby, if they don't want to have their baby, they can use the barrier methods. But if they want to have their baby, then they should be avoiding using contraceptives. Then the husband is at a risk of having the infection, or vice versa. Like husband is positive and wife is not positive, so there is a risk of transmission. So they can be using till they are conceiving. So they are at a high risk, but they are non-HIV. In that case, we are giving the two drugs, tenofovir and emtricitabine, as an FDC combination, okay? And as long as it is required. Now another is the schedule is that if suppose any person wants to have a sexual relationship with another person who is a known case of HIV, but still they don't want to use the barrier methods or any protection, but still they want to have the sex, in that case pre-exposure prophylaxis can be taken on demand, okay? And it is, although we don't recommend that it should be practically used left and right, but if it is a situation appears, then on demand it can be taken as a dose schedule of 211. And 211 is what? It is a number of the tablets of tenofovir and emtricitabine. The two tablets we are taking 24 hours before the sex. After this first dose, 24 hours after we are taking one tablet, and another 24 hours after the first dose we are taking another tablet. So 4 tablet का course है आपका, ठीक है. 2 tablets before the sex, then 24 hours after the one tablet, then again 24 hours after the first tablet, second tablet we are taking, ठीक है. So this is how we are trying to prevent the transmission as a pre-exposure prophylaxis. So this is all about our this group as sexually transmitted infections. Now in trachoma, only try to remember the strategy what we are following for elimination, that is safe strategy, surgery, antibiotics, facial cleanliness and environmental hygiene, and another is a GATT strategy, that is global elimination of trachoma. Another disease is tetanus, where the reservoir it is soil, and it is a disease which is absolutely preventable. Now, if a patient rarely develops the tetanus, in that case we are giving the penicillin and immunoglobulins. Now, just make a little correction if you had written as something different doses. For the treatment, if you are using the immunoglobulins, as a human immunoglobulin TET globe, the dose is 500 international units, and if you are using the animal immunoglobulins ATS, then the dose may vary from 20,000 international units to the 2 lakh international units. But if you are giving for prevention, okay, prevention means like suppose you had a road accident and you want to prevent the tetanus, in that case if you are using the immunoglobulins, then the human immunoglobulins or the tetanus immunoglobulin dose is 250 international units and the ATS dose is 1500 international units, ठीक है. So confuse नहीं करना. So for the prevention, this is the doses for human or the animal immunoglobulin, and for the treatment it is the dose as 500 or human immunoglobulins and 20,000 to 2 lakh is animal immunoglobulin. Now, how you can have an prevention is by active immunization. In our UIP schedule, we are giving the 7 doses of the tetanus as per the program, and the goal is to keep the antitoxin level of more than 0.01 international units. Okay? Don't confuse when we are giving the 7 doses, that first, second and third dose of pentavalent tetanus is a part of that. Then first booster we are giving 1.5 year, second booster 5 year, then TD at 10 year and TD at the 16 years. So these are the 7 doses of the tetanus vaccine we are giving. Now another is the post exposure prophylaxis, very commonly asked from us in the exam. So here it depends upon number 1, that what type of the wound person is having and when the person had received the previous immunization. Okay, what is the vaccination status? Which type of the wound are called as a minor wounds? If it is a clean, means not of a much of dust, it is of a short duration of less than 6 hours back, non-penetrating, not having a tissue damage or negligible tissue damage is there. ठीक है, because जितना damage ज़्यादा होगा उतना anaerobic atmosphere होगा and more possibility of germination of the spores of this tetanus. Okay, so no non-penetrating wound and negligible tissue damage is there, and other type of the wounds are the major category wounds. Then if it is the person who has received any booster within the past 5 years, then there is no need of the vaccine or immunoglobulin. In both the conditions, only the wound care we have to do. But our booster had been received within 5 to 10 years back, and then a TT injection will be okay in both the groups. And यहाँ पे खाली tetanus toxoid देते हैं, TD, tetanus and diphtheria we are not giving, because there is no role of diphtheria here. We are only giving the tetanus toxoid or tetanus. ठीक है? If a person had received the booster more than 10 years back, in that case mild category में only tetanus toxoid, but in the severe category we are giving the toxoid, the tetanus toxoid with immunoglobulin both. Okay, but if a person is non-immunized, had never received the vaccine in the past, or he doesn't remember, in that case immediate care के लिए minor category में we are giving the TT injection, and in the major category we are giving tetanus with immunoglobulins, and later on we are giving the complete immunization. Complete immunization मतलब first dose के बाद after 4 weeks we are giving a second dose of the TT, and then after 1 year we are giving a one booster, then another after 5 years we are giving the second booster. So this is what we are having, the complete immunization. Now neonatal tetanus has already been eliminated from India, and the criteria was the incidence was less than 1 per 1000 live births, and it is possible because of the two reasons. Number one, we had coverage of pregnant women with the 2 doses of the TD with more than 90% of the pregnant patients, and more than 75% deliveries are the institutional deliveries with the help of disposable delivery kits, keeping 5 clean methods. Another disease is the disease as leprosy, which is we are trying to make India free from leprosy. The loss of sensation in the order, the first the cold sensation goes, then hot. So temperature sensation goes first, followed by the touch and the pain. Now there is a damage to the nerves, and because of the nerve damage there is a loss of skin or ulceration is there. So the plantar ulcers are actually the secondary impairment in the leprosy. Primary impairment क्या है? Nerve damage है. Now a lepromin test, it's an intradermal test. We are only doing for classification of the type of the leprosy, and here we are taking a reading twice. First is after 48 hours, that is called as a Fernandez reaction. Second after 3 weeks, that is called as Mitsuda reaction. Special infrastructure or centers conducting the leprosy related activities, it is the survey, education and the treatment centers at the level of the PSC covering the 25,000 population. Then a clinical scenario will be given, and you have to identify whether this is a case of POSI or the multibacillary leprosy. Now based on the skin lesions, that is hypopigmented patch with loss of sensation, if it is 1 to 5 it is POSI, if it is more than 5 it is multibacillary. Now no nerve, if it is affected it is POSI, even if one or the more nerves are affected it is MULCI, that is a thickening of the nerves with the loss of sensation in the periphery, along with may or may not be the loss of the muscle power in that area. Now no smear should be showing the lepra bacilli, it is POSI. If it is even a one smear or one more than one, it is showing the lepra bacilli, it is multibacillary. Now in both POSI multibacillary, we are giving this pack of the drug, and it is again very important from your examination point, identification of the pack, the drugs and how it is being given. Once in a month we call the patient to the health center, and this is day 1 drug which is given under supervision the health worker. And this is the single white tablet is the Depson 100 milligram. The 3 capsules of clofazimine 100 milligram each, the total is 300 milligram, and these 2 capsules of rifampicin 300 milligram each, the total is 600 milligram. And patient should be observed for at least half an hour, she should not have vomiting. Then we hand over the pack to the patient, and patient is taking the daily Depson 100 milligram and clofazimine 50 milligram, and after 1 month empty blister pack patient brings back, and again the next pack is given. So this cycle goes on for 6 months in POSI and 12 months in multibacillary. Okay? Earlier we were giving the 2 drugs in the POSI. So if any question you could be coming across where the 2 drugs is given for POSI, just update that question. Now we are giving the 3 drugs in both POSI and the multibacillary. Okay? And yearly we are calling them for follow up for 2 years in POSI and yearly for 5 years in the cases of multi. Okay? And if in this follow up we don't find any relapse or any again the symptoms of the leprosy, then we say that patient is now finally cured, and we are removing the name of that patient from a register. Now how we can do the diagnosis of the leprosy? Any of these given 3 features should be there. Now earlier we were only diagnosing when we demonstrate the microbacilla, this AFB bacilli in the smear, but now clinical diagnosis can also be made. Okay? Now in the presence of any hypopigmented patch with loss of sensation, that is important. ठीक है, खाली hyperpigmented नहीं होगा, hyperpigmented के साथ loss of sensation is there. Now involvement of the nerves, thickening with the loss of sensation. ठीक है, थिकनिंग विद द लॉस ऑफ सेंसेशन, ऐसा नहीं खाली थिकंड है, लॉस ऑफ सेंसेशन भी होना चाहिए. दिस मे और मे नॉट बी एसोसिएटेड विद द वीकनेस और द पैरालिसिस ऑफ द कॉरस्पॉन्डिंग मसल्स. ठीक है, तो वीकनेस हो भी सकती है, पैरालिसिस हो भी सकती है और नहीं भी हो सकती, लेकिन थिकनिंग विद द लॉस ऑफ सेंसेशन इन द पेरिफेरल पार्ट. Mycobacteria leprae demonstration in any of the lesion, if it is there, like we are taking a smear from the ear lobule, we are taking a smear from nasal secretions on the nasal septum, or any of a skin lesion, if it is demonstrating the lepra bacilli, it is a leprosy. ठीक है, then we are trying that patient should be corrected for its deformities. So this is a disability prevention and the medical rehabilitation activity going on, and here we are giving the patient 12,000 rupees as an incentive to hospitalize and undergo for the correction of the deformities. ठीक है, because the patient will say that if I have to stay for 10-15 days, then how I am going to earn and support my family. For that we are giving 12,000 rupees to the patient. Simultaneously we are providing them the ulcer treatment kits and special footwear, so they should not have a repeated trauma to foot. So this is disability prevention. Now if one new patient of a leprosy had been diagnosed in the family, then we are giving the chemoprophylaxis to the close contact. ठीक है, सो यहाँ पे 2-3 क्वेश्चंस है. नंबर 1, व्हाट वी आर गिविंग एज अ chemoprophylaxis is rifampicin. How we are giving? Only the single dose of the rifampicin. Adult dose is 600 milligram. It is directly observed supervised. ठीक है, so person should not be vomiting for half an hour after taking the tablet. The next point is who are considered as a close contact. Any person who is living, working और हैविंग द सोशल एक्टिविटी. ठीक है, लाइक मॉर्निंग वॉकर फ्रेंड्स हैं, क्लब फ्रेंड्स हैं, हु आर स्टेइंग फॉर 20 hours per week or more together for 3 months or more with a newly detected leprosy case in the last 1 year. ठीक है, last 1 year में whosoever is coming in contact of the leprosy person for more than 3 months and around 20 hours or more per week, that person should be having the risk of leprosy in future and should be given the rifampicin chemoprophylaxis. Then our global goal is, that is, we have to make zero leprosy by 2030, and nationally we are running for leprosy free India. Now please listen carefully. Now all the programs in India are the elimination programs or control programs. It is the only program which is a eradication program. So we are having a national leprosy eradication program to make an leprosy Mukt Bharat by 2027. These are the various objectives, targets and indicators. Important, try to remember. Okay, so we have to bring down the prevalence at the district level ओवरऑल एट लेस देन 1 per 10,000. ठीक है, एनुअल जो हमारे न्यू केस डिटेक्शन रेट है, इट शुड बी लेस देन 10 per 1 lakh. जो कम्युनिटी है, जैसे कैसे याद रख लोगे, लाइक मैटरनल मोर्टालिटी रेशियो में क्या है, डिनोमिनेटर और मल्टीप्लाइंग फैक्टर 1 lakh है, तो यहाँ पे भी 1 lakh लेंगे एंड इट शुड बी लेस देन 10 per 1 lakh. ठीक है, बट उसमें से जो ग्रेड 2 डिसेबिलिटी केसेस हैं, मीन्स एडवांस डिसेबिलिटी केसेस, नेशनल लेवल पे शुड बी लेस देन 1%. ठीक है, 1% ऑफ दिस टोटल न्यू केसेस. सो अगर आपको एक्चुअल वैल्यू चाहिए, सो 1% ऑफ दिस लेस देन 10 per 1 lakh आएगा आपका लेस देन 1 per 10 lakh. तो कैसे याद रखोगे, अपोजिट कर लो. ठीक है, सो दिस इज लेस देन 10 per 1 lakh इज द न्यू केस डिटेक्शन, एंड द ग्रेड 2 डिसेबिलिटी के less than 1 per 10 lakh. That is less than 1% of the total new cases. And the disability among the new children of less than 15 years should be 0, and there should be 0 stigma in the society. Now what are the indicators? The epidemiological most important indicator is annual new case detection rate. The most important operational indicators means if you are properly working, conducting your program is a new case with grade 2 disability, because if we are detecting the leprosy cases earlier, then patient should not be going into grade 2 disability. So, most important operational indicator is new case with a grade 2 disability, and most important epidemiological indicator is annual new case detection rate. Now, indirectly the prevalence is suggestive of case load or planning of treatment services. If prevalence is high, it means our patient is lasting for a very longer time and we have to change our treatment facilities. Okay. And incidence is reflecting the effectiveness of the program, means we are treating, then we are trying to prevent the transmission of the disease to others. So, incidence is reflecting the effectiveness of the program, prevalence is reflecting the planning of the treatment services. Leprosy vaccine, it is under the trial, we are giving along with the rifampicin capsule. Some other activities, one question already had been asked in a previous PYQs, that is leprosy musket is a girl, Sapna, and Asha, it is a main worker for this program, and doing an household search, and activity is called as ASBL. It is Asha based surveillance for leprosy suspect. So, Asha is visiting house to house, and any patient who has a hyperpigmented patch with loss of sensation or thickening of the nerves is detected and sent for further examination and confirmation. Okay. Then we are now trying to detect the leprosy in the school children, in ICDS centers, under the Rashtriya Bal Swasthya Karyakram, Rashtriya Kishore Swasthya Karyakram, or the adult screening under the non-communicable diseases program under Ayushman Bharat. Whenever we are examining the patient of any age, we are looking for leprosy also. Now, another question is asked is, if a patient is on a anti-leprosy drug and develop a reaction, then we are not going to stop the anti-leprosy and we have to continue the anti-leprosy. Along with that, we have to add the steroids. And lepra reactions could be of the two types. Because of type 4 hypersensitivity reaction, we are having a type 1, rule of 5 is there, type 1 with type 4 hypersensitivity, where existing lesion they increase in the size and they become red hot tender. But if it is a type 2 lepra reaction, because of the type 3 hypersensitivity, there is a multiple new lesion appears in the skin, multiple new lesions appears in the skin, and that is why it is also known as erythema nodosum leprosum. Now, if we talk about some extra edge points are that what are cases are called as the defaulters or the new case. New case means who had never received the MDT or the multi-drug therapy in the past, who is taking for the first time. Then who are called as the defaulters? Defaulter means who were taking the MDT, but they had not taken this for 12 months. ठीक है, 2-3 month का gap होता है, तो whatever the left packs are given, left packs are there, we are giving. Like suppose a patient is of a case of multibacillary, and she has taken the treatment for 8 months. Now she has not taken the treatment for the next 4 months, and again she is coming after 4 months. So remaining 4 packs, whatever is left, we will be giving them. But suppose a patient is coming after a gap of 12 months. ठीक है, 12 month के बाद आता है, तो we consider them as a defaulter. And suppose 4 packs she has already taken. She is a case of a paucibacillary. 4 packs ले लिया था उसने 4 month का, and 2 month का बचा था. But now she was not coming for 12 month. So अब आएगी तो फिर से we will be restarting with the new box. Actually क्या होता है कि patient wise boxes जो होते हैं beginning में ही it is coming from the center, and whole box is having a full months of the therapy. Like अगर paucibacillary है तो 6 monthly packs होंगे, so 6 packs will be there. So अगर ऐसा patient है जो defaulter है, who has taken a treatment for some time, not taken a medicine for 12 months, अब उसका नया जो हम restart करेंगे treatment, it will be started with a new pack. ठीक है, so restart the treatment as per the new schedule and with the new pack, with the new schedule with new pack. ठीक है, a new pack, और न्यू बॉक्स से हम उसका ट्रीटमेंट स्टार्ट करेंगे. सो अगेन उसको फिर हम 6 पैक्स या 6 मंथ का ट्रीटमेंट देंगे. ठीक है. देन हु इज कॉल्ड एज द पेशेंट हु हैज टेकन एन एडिक्वेट ट्रीटमेंट. एडिक्वेट मीन्स कंप्लीट ट्रीटमेंट ले लिया, दैट इज 6 month का ट्रीटमेंट फॉर द पॉसिबेसलरी एंड द 12 month का ट्रीटमेंट फॉर द मल्टीबेसलरी, दैट इज अ एडिक्वेट ट्रीटमेंट. ठीक है. सो न्यू केस मतलब फर्स्ट टाइम टेकिंग एन मेडिसिन, डिफॉल्टर नॉट टेकन अ मेडिसिन फॉर 12 months, एंड रिलैप्स मीन्स कंप्लीट उसने ट्रीटमेंट ले लिया, उसके बाद again having the signs and symptoms, that is what is a relapse. And adequate treatment किसका है? 6 month for the MDT possibacillary and the 12 month for the multibacillary. ठीक है. and यहाँ पे एक और point आप ऐड कर लीजिए, that if there is no signs and symptoms of relapse in follow-up, no signs and symptoms of relapse and follow-up. ठीक है. and we know that for 2 years follow-up is for POSIB and 5-year follow-up is for multi. These patients are known as cured. ठीक है. so these patients are known as cured and their name is removed from register. Name is removed from register. So no signs and symptoms of relapse is seen within the follow-up. They are known as cured patients and then their name is removed from a register. ठीक है. अगर follow-up में signs and symptoms of relapse मिलेंगे तो मतलब patient is called as a relapse case. ठीक है. So this is about our the treatment of leprosy and leprosy disease. Then another infection is intestinal infections, where the common presenting feature is diarrhea. If it is a mild or moderate diarrhea, we are giving ORS. The composition, once a sachet of ORS is dissolved in 1 liter of the boiled cool water, its osmolarity is 245 millimole, which is having 75 millimole of sodium and glucose same as 75 millimole, and the dose of ORS is 75 ml per kg of the body weight to be given within 4 hours. ठीक है. and we have to explain to the community how to prepare ORS by method of demonstration. If ORS is not available, then we can go with other fluids like coconut water or the rice water with the salt or lemon water with the adding the pinch of salt and sugar. We can give the OPV to a child with a diarrhea, but consider this as a 0 dose and we have to repeat the dose after 4 weeks. If it is a severe diarrhea, then we have to give the IV fluid in the dose of 100 ml per kg of the body weight in the 3 to 6 hours in the divided doses. The first is that is 30 ml per kg and the second is 70 ml per kg. Now fluid to be preferred in order, the first preference should be given to the diarrhea treatment solution. Not available, then we can go with Ringal lactate. Not available, we can go with normal saline. Now along with this we are giving the zinc and the dose it depends upon the age of the baby. अगर less than 6 month है तो 10 milligram per kg, अगर more than 6 month है 20 milligram per kg per day, it is given for 14 days. Polio, it is a disease which is eliminated from India and now we are polio free. No polio case has been reported in India since 2011 and as it is eliminated and it's still our nearer countries are having polio, so we are still continuing our control activities. Okay, so we are having the polio elimination program and this we are having a routine polio vaccination. Every year we are having pulse polio immunization. Pulse means at a time we are giving the polio vaccine OPV 2 doses at a gap of 4 weeks to all the children between 0 to 5 years to maintain the herd immunity of intestine. Okay, then AFP surveillance, again a very important is any child who has been reported with flaccid paralysis similar to the polio paralysis should be investigated. to find out whether it is a polio or non-polio. So, the age group is 0 to 15 years and the stool examination is done to confirm the polio or to exclude the polio. The sample what we are collecting is 2 samples within 14 days of the paralysis to be transported in a reverse cold chain at +2 to +8, should be reaching to the lab within 48 hours and report should be available within next 4 weeks. And if it is found to be non-polio, then okay, no problem, and we can be stopping our investigation at this point. Now, what are the indicators for the AFP surveillance is? Now, please listen. If non-polio AFP cases should be more than 1 per 1 lakh, means some of the non-polio paralytic cases should be reported at a rate of more than 1 per 1 lakh population, and more than 80% of the samples what we are sending should be checked and report should be available. Next is cholera. It is a disease which is absolutely preventable by health education. It is father of public health, and how we can be preventing by educating the community to use the safe drinking water, wash hands before meal, use the cover food, take the cholera vaccine and keep environmental clean. Then we are having the vaccine of both live and killed available against the cholera, and these are the bivalent vaccines available against O1 and O139 serogroups. This is a disease which is coming under the international health regulation, means we have to inform to WHO within 24 hours of occurrence of this disease. Correction of dehydration either by ORS or IV fluids depending upon the severity. The drug of choice for treatment of cholera in adults is doxycycline. In pregnant patient it is azithromycin. In the cholera epidemic, tetracycline is distributed as chemoprophylaxis. There is a high risk of bacilli in stool and vomitus, which is in the yellow category of the biochemical waste, liquid chemical waste, and we have to disinfect with 5% cresol and discard in normal domestic drain. Source is infected well water, so we are doing the chlorination every 24 hours. Both live and killed vaccines are available against cholera. Typhoid is a disease of index of the general sanitation of our country. Man is supposed to be the only reservoir for typhoid. The best test for the diagnosis is blood culture, but it is expensive. So, in the first week we are doing the detection of IgM antibodies by typhi.m test. Drug of choice for cases is cefixime, but in the resistant cases we can be giving ceftriaxone with azithromycin. Disinfection of the liquid chemical waste is by 5% cresol. Both the type of vaccines are available, live and the killed vaccines. Now we are having the conjugate vaccine also, and the advantage for this is that it can be given to children less than 6 months of the more than 6 months of the age till 45 years. Single dose is enough to protect against typhoid. The most common hepatitis, which is in the form of chronic carrier stage, is hepatitis B. Hepatitis with liver cancers, it is B and C both. Hepatitis with chronicity, it is C, and hepatitis in pregnancy, which is causing high mortality, it is hepatitis E. Achilles, we are having both the live and killed vaccines, but killed is most commonly we are using. Hepatitis B is again a vaccine which is only the killed form vaccine, and preferred dose schedule is 0, 1 and the 6, but as in our national program now we are using pentavalent, so we had modified the schedule. In hospital deliveries we are giving the 4 doses, 1 at the birth, hepatitis B, and these 3 doses 6, 10 and 14 as pentavalent. Okay? But in the home delivery, because birth dose should be given only within 24 hours, so we are giving the 3 doses as pentavalent at 6, 10 and 14 weeks. If a mother is hepatitis B positive, how we can prevent its transmission to the newborn baby? So, if a mother is hepatitis B positive, how we detect? By detecting the surface antigen in the screening. Then we look for envelope antigen also. If both are present, two antigen present, two actions in the baby, vaccine and immunoglobulin. But if one antigen present, only surface antigen, and envelope is absent, one action, only vaccine we are giving to the baby after delivery. If surface is present but we don't know the envelope status, in doubt we are giving the two doses or the two action, vaccine and immunoglobulin, both to the baby. One worm which is related to anemia, it is ankylostomiasis, and the spread is through the skin, means fecal route of transmission is not there, but it is because of the open field defecation. So, open field defecation, say these the eggs are coming out, they are germinating in soil, and then these larvae they enter through the skin, okay, through the skin entering into the intestine. So, we have to break this chain, avoid open field defecation. Or there could be the simple living as parasite is Ascariasis. So, most common worm infestation in India is Ascariasis, but it is causing anemia is hookworm. And hookworm mein we are having one index commonly asked is the Chandler index, is how many eggs of the hookworm are present per gram of this stool is the Chandler index, okay. And if it is more than 300, then we say it's a major public health problem. And to avoid this condition, we are now having a national deworming program, means twice in a year we are giving albendazole tablet on the national deworming days. And what are the national deworming days? We know on the 10th of February and the 10th of August. These are the national deworming days are there. And single albendazole a tablet 400 milligram twice in a year we are giving in the age group of 1 to 19 years. As well as we had already discussed, at 4 months of the pregnancy and the second trimester we are giving a single dose of albendazole to all our pregnant patients also. Now, the next group is respiratory tract infections. Measles is a very important disease. A disease which is before the rash, once a running nose starts, had a rash opposite the second molar teeth in the buccal mucosa, it is a complex spot. 10 to 14 days of the incubation period, single best answer is day 10. Period of communicability is 4 days before to 4 days after the rash. Complex spots are seen in the before the rash in pre-eruptive phase. Most common complication of the measles is otitis media. Rare complication is subacute sclerosing panencephalitis. Prevention, it is by giving prophylactic measles vaccination as per the schedule, 2 doses we are giving. Post exposure, if a patient child is of a good immunity, within 3 days of the exposure we can give the measles vaccine, because here the seroconversion time is less than incubation period. Incubation period कितना है 10 days का, and seroconversion is 7 days, so 3 days का window है. So, good immunity अगर है तो within 3 days of exposure we can give the measles vaccine, otherwise in all the situations we have to give immunoglobulins only. ठीक है, and I think this we had already talked about. If a child is having the measles, in that case we are giving prophylactic vitamin A supplementation also. अगर baby में there is no vitamin A deficiency symptoms हैं and a baby has not received the vitamin A in the last 1 month, then we are giving the 1 dose. But if a baby is with the measles and malnourished hai, in that case we are giving the 2 doses. Okay? And the treatment is, that is only isolation. Now always remember, agar active stage hai measles ka, in that case we are not giving the measles vaccine. Okay? And once the child has the measles also, natural immunity hoga, so that child again doesn't require the measles vaccine. So, we have to give only prophylactically, pre-exposure only, post-exposure only within 3 days of exposure. Now, for the elimination, that is what is our goal of measles elimination by 2026, and we are having the 2 strategy. One is a catch up, keep up and follow up strategy, and another is the accelerated measles mortality reduction strategy. And what is the catch up age for the measles? Catch up age of measles is 9 months to 10 years, means 9 months to 10 year age group mein we are giving a 1 dose of measles vaccine irrespective of their vaccination status to all the children. Okay? So this is what is the catch-up age group for measles vaccination. Now, chickenpox में the rash is important. This is an image based question, and pleomorphic rashes means all the type of rashes are seen. They had a centripetal arrangement. They are mainly on the central part of the body and they spread towards the periphery. Okay? So, spread is towards the periphery centrifugal, but they are present on the centripetal or the central part of the body, and the crust is not containing viruses, crust is non-infective. Then it can be prevented by a vaccine, that is live vaccine, and it is not a part of our program. Now, if one person in the family is having chickenpox, the next step is how to protect the others is that don't jump for vaccine or immunoglobulin. You have to go for varicella zoster IgG antibodies. कि अगर IgG एंटीबॉडीज प्रेजेंट हैं या एब्सेंट हैं, ठीक है. अगर IgG एंटीबॉडीज प्रेजेंट हैं देन नथिंग हैज टू बी डन बिकॉज दैट पर्सन इज क्वाइट सेफ. बट अगर IgG एंटीबॉडीज एब्सेंट हैं varicella zoster and if there is no pregnancy, the good immunity is there and within the 5 days of exposure we can give the varicella zoster vaccine. Otherwise, in all the conditions we have to give the immunoglobulin. And how much is the dose? Dose is 12.5 international units per kg of the body weight to be given as single intramuscular injection. Then influenza. Human influenza is because of H1N1, H3N2, Victoria and Yamagata, and against these 4 strains we are having our quadrivalent vaccines. Every year they are changing its antigen. The phenomena is sudden changes, the shift phenomena, the gradual changes, the drift phenomena. The category C are most dangerous because they are having the multi-organ failure. Progressive condition is progressive stages there. Suddenly they have been having a multiple organ failure, they require hospitalization. The rest the category A and B can be treated at home. Then the drug of choice for the treatment is oseltamivir or the Tamiflu. Try to remember the doses. The adult doses, that is the more than 40 kg weight hai, 75 milligram twice a day we are giving for 5 days. Now for the chemoprophylaxis we are also using the oseltamivir in the same dose like in the adult more than 40 kgs. It is 75 milligram, but it is given once a day for 10 days. Okay. Then we are having both the type of the vaccines, live and the killed vaccines here. The live is given by nasal route while killed is given by intramuscular route. The first priority group where we should be giving the influenza vaccine is in the pregnant patients. Okay? And in the pregnant patients obviously we will be giving the killed vaccine and it is given at the 5th completed month. Single dose intramuscular injection we are giving. Then another important disease is meningococcal meningitis. Now here our main goal is the early diagnosis and the treatment. Obviously prevention will be better than the early diagnosis. So first of all we should be trying to have a vaccination of the community to prevent this condition. If vaccination is not possible, then we have to give the chemoprophylaxis at the time of epidemics, and if chemoprophylaxis is also not practically possible, then we have to do the early diagnosis and treatment. Why? Because with the early diagnosis and treatment, the case fatality rate is only 10% and without any treatment, the case fatality rate is 80%. Now, we are having the vaccine available for the 4 serotypes, that is A, C, W135 and Y, and that's a quadrivalent vaccine is the polysaccharide vaccine. Now we are having the separate conjugate vaccine, it is for the B strain also. Okay? So earlier we were having only the polysaccharide vaccine for the 4 strain ACW135 and Y, but now we are having the separate conjugate vaccine for B strain. Okay? The drug of choice for treatment of the cases is ceftriaxone or cefotaxime. For the carriers, it is ciprofloxacin. Okay? But agar pregnancy mein you have to give the chemoprophylaxis or the post-exposure chemoprophylaxis in a pregnant patient, then we are giving the ceftriaxone. But agar general population mein you have to give, then you are using the ciprofloxacin. Earlier we were giving rifampicin, but now rifampicin we are not using because this is the drug we are preserving for tuberculosis patients only. The mass chemoprophylaxis, again it is recommended again by ciprofloxacin only, because at any cost we want to reduce our number of the cases of meningococcal meningitis. Okay? So mass vaccination is also advised. Now diphtheria and pertussis. Diphtheria is a condition causing the bull neck appearance, swelling in the neck, but pertussis is causing the continuous constant coughing, and because of that coughing the child can have the hemorrhage also, anywhere, brain hemorrhage, bleeding from any part, subconjunctival hemorrhage, might be having the difficulty in breathing also. Okay, and in the diphtheria, if you examine the throat, you can find a pseudomembrane. High number of subclinical cases and carriers are seen in diphtheria, but there is no subclinical cases and carriers are seen in pertussis. Okay, now a period of communicability is very important for diphtheria. It is from the infection till 4 weeks or 28 days after the infection it is seen. Then drug of the choice for treatment of cases of diphtheria is penicillin with antitoxin. Okay? But for the close contact we are giving erythromycin as chemoprophylaxis, and for the carriers also we are giving erythromycin. But in the cases of pertussis, for the cases the drug of choice is erythromycin, and to the close contact also it is erythromycin. Now both the conditions can be prevented by a routine vaccination as the DPT vaccine. 3 doses we are giving with pentavalent. Okay, then we are having the 2 boosters of the first booster and the second booster at 1.5 year and 5 years. Then small amount of diphtheria we are giving as TD vaccine at 10 years and 16 years. Okay, so purpose is to keep the antitoxin level of both the toxins is more than 0.03 international units. But always remember that this is not effective against the carrier stage. ठीक है, ये diphtheria के carrier stage को prevent नहीं करती है. Now, if one person in the family is having the diphtheria, how you are going to prevent the other contacts? If that child had received any of the diphtheria vaccine or toxoid or the DPT vaccine within 5 years, then only the erythromycin tablet is given as a prophylaxis. Okay, but if the child has not received any of the vaccine dose, primary dose or the booster in the past 5 years, in that case we will be giving the DPT booster as well as the erythromycin. But if the child is not immunized at all, means had never received the DPT vaccine, then we will be giving erythromycin for the immediate protection, small amount of the antitoxin and the full course of the DPT vaccination. Okay, if a baby is less than 7 years old. But pertussis के लिए we are giving erythromycin to all the close contact, or now we are giving the Tdap vaccine to the mother at 30 weeks of pregnancy. So it is protecting the baby in first 6 weeks after delivery. Mumps में commonly they ask about the complications, and clinical feature is one side of the swelling over the salivary glands. ठीक है, so pancreatitis is commonly seen in children. Ophritis or orchitis unilateral, it is seen in adolescent children, and encephalitis or meningitis, it can be seen in any of the age group. Now rubella, and this we are having on the soft palate, the rashes are seen, that is inside the mouth, it is called as the Furchimer spots. Like measles mein we had the Koplik spots, and यहाँ पे rubella mein we are having the Furchimer spots. Mother, if it is having infection in the first trimester, the baby is likely to be born with the congenital rubella syndrome, including cataract, sensory neural deafness, and congenital heart disease. The most common is patent ductus arteriosus. And the most dangerous period is the first trimester. But after 20 weeks, if a mother is having infection, then there is not a risk of congenital rubella syndrome. So it is absolutely prevented by giving the rubella vaccine. So in our national program, we are giving as measles containing vaccine MR or MMR to all our children. Now यहाँ पे preference is given, and like in influenza we had seen the preference was given to the reproductive female, but यहाँ पे the preference is given to the influenza में the reference was given to pregnant patients, but in rubella, influenza में किसको था preference था? Pregnant patients का था, and in rubella the preference is given to the reproductive female who are going to become pregnant. ठीक है, so first priority of vaccination is to the reproductive female, and then we are giving to the 1 to 14-year children, and then the routine vaccination is given. Rubella vaccine is absolutely contraindicated in pregnancy. ठीक है, the same is that if one person in the family is having the rubella infection, and how you are going to protect the other one, then you have to check for rubella IgG antibodies. If it is present, then they are safe, no action has to be taken. But if it is absent and the patient is pregnant, ठीक है, patient is pregnant, less than 20 weeks का है, in that case we are giving the rubella immunoglobulins. ठीक है, like in other situations nothing has to be done. ठीक है, even a pregnancy अगर more than 20 weeks है या non pregnant patient है, no action because mild infection, natural immunity. So only the one situation we are giving the rubella immunoglobulins, that is if IgG antibodies are absent and the patient is pregnant with a pregnancy duration of less than 20 weeks, then we are giving the rubella immunoglobulin, and the total dose is 20 ml we are giving. Same is, we are checking for the rubella immune status before the conception also, and if a patient couple comes to the clinic, so in the female we are checking for IgG antibody. If it is present, we say okay, you can plan your pregnancy. If it is absent, then we say okay, we will give you the vaccine and you have to wait for 1 month. So use a contraceptive for 1 month, and only after 1 month you can plan. The next disease is pneumonia. Pneumonia में you have to identify that which is the type of pneumonia and in which category of IMNCI you have to take the child. ठीक है, so based on the respiratory rate, अगर respiratory rate normal है, so that is a no pneumonia. आप running nose हो सकता है, but respiratory rate normal है तो no pneumonia. But अगर respiratory fast है तो pneumonia and severe pneumonia, and this is depending upon the age also. So you should be looking for the age of the baby in the question. अगर 0 to 2 month है, so normal rate is should be less than 60 per minute, and if it is 2 to 12 month है, तो normal it should be less than 50 per minute, and अगर more than 12 month है, should be less than 40 per minute. Then along with the high respiratory rate, if there is a presence of accessory muscles, then listen carefully, the baby can be either pneumonia or the severe pneumonia depending upon the other conditions. Now, if accessory muscles are present and the baby is more than 2 months without any HIV infection, it is included as pneumonia. But if a high respiratory rate with the presence of accessory muscles in the 0 to 2 month baby, irrespective of HIV है नहीं है, or more than 2 months with HIV, that baby should be considered as severe pneumonia, or any presence of the danger signs like baby is not able to take orally, or baby is unconscious, any of signs and symptoms of the or the danger signs are present, it is a severe pneumonia. So अगर danger signs present है या accessory muscles in a 0 to 2 month baby है, or the accessory muscles in more than 2 month baby with HIV, that is considered as a severe pneumonia. And IMCI category, it is like a traffic signal color, that light का color है, that is green for no pneumonia, yellow for pneumonia, and instead of the red we are having pink for severe pneumonia. Now green means home based ambulatory treatment you can be having, yellow means you have to treat and follow up of the person, and in the pink case you give the supportive treatment, pre-referral treatment, and immediately you have to refer the child to the higher center. Now coming to a very important disease, now we are having the tuberculosis elimination program with this logo, and the first test for the diagnosis of tuberculosis is the sputum examination. Now 2 samples we are taking, one is a spot sample and another is the next day morning sample, because morning sample it is concentrated and having a higher chances of detecting the tubercle bacilli. Now we are having an active surveillance, so now we can collect the center sample in the periphery also, in the village also by ASHA worker or multipurpose worker, and we are transferring to the DMC centers where it is checked. So the important infrastructure is the DMC designated microscopy centers, which is 1 per 1 lakh population. Okay, and we are transferring in a triple layer packing, so nobody should getting infection in between. Any of the sample, if it is positive, that patient is declared as sputum smear positive, and for a positive smear, the number of the bacilli should be more than 10,000 per ml of the sputum. Then latent TB infection means a person is having the tuberculosis infection but no signs and symptoms of the disease is detected. Best is by the IGRA test. Okay, so the best test for the diagnosis is the IGRA test. It is very specific, but only the problem is it is expensive. Okay, so now we are using the CYTB test, which is having the same result as an IGRA test, but it is not very expensive. It is easy to administer. It is like as an intradermal test of a tuberculin test. Okay, so now we are preferring the CYTB test for detection of the latent tuberculosis. So if a question is asked, what is the best test for the diagnosis of the latent tuberculosis, it is the IGRA test. But what is the preferred test is, preferred test is CYTB test. Okay, CYTB test, because it is having the same specificity as IGRA, same specificity as the IGRA, but it is easy to perform. It is easy to perform. ठीक है, so same है specificity as the IGRA test, but it is easy to perform, that is CYTB test. ठीक है, then case finding. Now we can be having the active case finding, like going house to house and try to find out the suspected cases, or we can be having the intensified case finding. Intensified means we are going in other clinics of other diseases, like in HIV clinics or non-communicable disease clinics, because tuberculosis is very associated with these diseases also, or we are trying to find the tuberculosis in the high risk population. Okay, so this is what is the tuberculosis finding, and this is done by ASHA worker. So active finding जो होती है, it is done by the ASHA workers, and we are looking for the presumptive symptoms in the patients, and these are called as the 4S screening. 4S screening, it is done in these individuals. Now we are looking for the 4 symptoms for the screening, and what are those 4 symptoms? That we are looking for any presence of the cough or fever if it is more than 2 weeks duration. Then if there is a weight loss of more than 10%, weight loss of the more than 10%, or if there is a presence of night sweat. Okay, there is a presence of night sweats. So these are the 4 symptoms for the screening: the cough and fever for more than 2 weeks, the weight loss for more than 10%, and night sweats are there. Now we are categorizing our patients as the drug sensitive TB, means they are responding to rifampicin. Then we are having the drug resistant TB. Now drug resistant TB is multi-drug resistant, pre-XDR and XDR. Okay, so multi-drug resistant means they are resistant to the basic drugs of tuberculosis treatment, that is INH and rifampicin. But if in addition to INH and rifampicin they are resistant to the quinolones, then it is called as a pre-XDR. Now, in addition to INH and rifampicin and the quinolones, if they are resistant to the first group A drugs which we are using for the tuberculosis as bedaquiline and the linezolid, they are called as extensive drug resistant TB. Okay. Now, a little bit a higher point, but I don't want you to confuse from the multi-drug resistant to polydrug resistant or the monodrug resistant. Okay, now listen carefully. Multi-drug means they are resistant to the basic drug as INH and rifampicin. But other than the INH and rifampicin, if they are resistant to the any of the first line drug. So what are the other first line drug is? It is ethambutol and pyrazinamide. So if they are resistant to only single a drug of first line other than INH and rifampicin, they are called as monodrug resistant. But if they are resistant to more than one first line drug other than the rifampicin and INH, they are polydrug resistant. Okay? And if they are resistant to INH and rifampicin, it is multi-drug, and pre-XDR with quinolones with bedaquiline and linezolid XDR, extensively drug resistant cases. Now treatment is so that's why now there is a compulsory CB NAT to be done before the start of any treatment. So to look for rifampicin resistance or the rifampicin sensitivity. Okay. So drug sensitive TB means they are responding to the first line drugs, and here we are having the 6-month duration. It is divided into the 2 phases, 2 months of the intensive phase HRZD, 4 months of the continuous phase HRE. Now intensive means every dose is given by the health worker, and continuous means the patient is taking medicine on its own. Now MDR and or the rifampicin resistant TB may now the preferred protocol is it is a BPAL-M regime. Now BPAL-M regime it is used for the MDR cases and it is given for 6 months. ठीक है, लेकिन अगर pre-XDR है तो moxifloxacin it is resistant, so we are only giving the BPAL regime. Now if a BPAL is M regime, it is contraindicated, like in a patient of pregnancy or if there is any allergy to any of the drug. In that case we can be going for shorter or the longer MDR treatment. But now we are not giving the streptomycin as injectable, and we are only giving the oral treatment. Okay? The drugs, if you can remember for a short oral MDR, it will be okay. The 7 drugs we are giving in the intensive phase and it is lasting for 4 to 6 months, and the 4 drugs we are giving in the continuous phase lasting for 5 months. So total duration is 9 to 11 months. Then why we added these drugs bedaquiline and the delaminate? Because they decrease the sputum conversion time, means time required for a sputum to disappear all the bacilli. Normal time it is 3 weeks, means patient is responding to the drugs, then within 3 months, the 3 weeks the sputum should become negative after start of the therapy. Then how we do the follow by sputum examination? It is at 2, 4 and 6 months in the drug sensitive TB, and based on that we can say that patient is responding to the medicine or patient is a failure case. Okay? And this tablet what we are giving is the FDC model we are having, means a single tablet which is having all the required drugs, and number of the tablets depends upon the body weight, and that's why we are having the different groups based on the body weight. These are called as a bands. So adults में 5 categories हैं, 5 groups हैं, and children में we are having the 6 bands are there. Now we are having the software for reporting of all the tuberculosis patients, their medicines, their follow-up. It is Niksha portal, and this is the logo for the Niksha portal. So all the patients who are treated under the government sector are reported in this portal, but it was difficult for the patients who are treated in the private sector to be reported. So now the government made it mandatory that all the private practitioners also, they have to report to the district level every month about the patients they are coming across, the new cases they are treating, or any final outcome of the patients of the tuberculosis, they have to inform to the district level. All on the Niksha portal they can be creating their login ID, and every new patient detail they have to enter. Another very important is the Niksha Poshan Yojana, and to overcome malnutrition we are giving a cash incentive of 1,000 rupees per month till end of the therapy in all the type of tuberculosis. Here maybe a drug sensitive MDR, XDR or pre-XDR, in all the type of tuberculosis patient irrespective of their socio-economic status, also 1,000 rupees per month till end of the therapy. Then for reporting of the drug compliance, we are having the DOTS 99 system, that is for drug adherence. ठीक है, like adult dose जो होती है 2 tablets in the morning and 2 tablets in the evening. So once a patient is opening the tablet after the second dose, it is having the toll free number. So in the intensive phase, the DOTS agent has to give a missed call on this toll-free number that they had given the medicine to the patient, and in the continuous phase this action has to be done by patient himself or herself. Okay, so it is registered in the Nixia portal that you had taken the medicine. So it is for drug adherence. Then if a mother is having the active tuberculosis within the 1 month before the delivery, so there is a possibility that a sputum is having the bacilli. In that case, we have to give the protect the newborn baby for the tuberculosis, and then we are giving the isoniazid. Okay, so we don't give the BCG to the baby at that time, we give the isoniazid in the dose of 10 milligram per kg of the body weight for the 3 months, and after 3 months we do the tuberculin skin test, and if it is negative we stop the INH and give the BCG. But agar positive hai, so no need to give the BCG now, we continue the INH for another 3 months and total 6 months as an treatment for latent infection we are going for. Okay. Now agar patient is diagnosed with TB and HIV together at a time, okay, so first of all we have to start the anti tuberculosis drugs for the 2 weeks, and after 2 weeks we have to add the ART drugs, not started together. This is to avoid the IRIS, that is immune reconstitution inflammatory syndrome. So first start ATT and continue for 2 weeks, after 2 weeks add the ART in that. This we had already talked about. If a patient is of HIV, then we have to give the tuberculosis preventive therapy for preferred is, that is the 3 HP regime is preferred. Now agar tuberculosis is seen in pregnant patient, so if it is a drug sensitive TB, then the same treatment in all the trimesters same as a non-pregnant. Lekin agar MDR TB hai, so drugs are not safe. So if it is MTP possible, means a pregnancy is, if it is less than 24 weeks, do the MTP and then start the BPALM, because BPALM is contraindicated in pregnancy. But agar patient is beyond 24 weeks where the MTP is not possible, or patient is not willing for MTP, in that case we have to give the modified treatment, short oral MDR with or the long with modification till the delivery. And modification में क्या करेंगे कि जो ethonamide है and cyclosporin है, this is not safe in pregnancy, so we in place of this we are giving the para amino salicylic acid. Then जो हमारा goal है that we have to end the or eliminate the tuberculosis in India by 2025. जो global goal है, so India का क्या है, national goal क्या है, to eliminate by 2025, and जो global goal है that we have to eliminate or the end to global TB by 2035. तो दोनों में 10 years का difference है. जो global हमारा target है that is 90-90-90, मतलब 90% patients of the TB should be diagnosed and should be treated, then reach the 90% of the high risk population, and those who are on the treatment 90% should be having the treatment completion or success rate. Now HIV का strategy क्या था, prevention, test and treat. यहाँ पे है test, treat and complete treatment is the main strategy for tuberculosis. ठीक है. Now यहाँ पे इंडिया का जो गोल है, how we are trying to achieve this elimination by 2025, that is active case finding है. Then we are having a private public private sector partnership, and the activity what we are running is the JEET campaign, that is a joint efforts to eliminate tuberculosis. So it is a private sector and the public sector joint involvement is present. Then India का जो हमारा target है 80% reduction in the TB new cases, 90% reduction in the deaths because of the TB, and 0 patient having the excessive expenditure in the family because of the tuberculosis. Okay, so no patient should be falling in poverty because of the tuberculosis, because every treatment and drug is available free of the cost in the government sector. जो strategic pillar है, we can remember as a DTPB, that is detect, treat, prevent and build the policy. So these are the 4 strategic pillar of our program, that is detect, test, treat, prevent and build. Important infrastructure, the DMC centers 1 per 1 lab, where all the samples are checked. They are again rechecked at the tuberculosis unit, and all positive samples are rechecked and 10% of the negative smears are checked. Okay, so they are checking all the positive smears reported at the DMC, and randomly they are checking the 10% of negative smears, and roughly the 2 of the DMCs are covered under tuberculosis unit. So it's covering around 1 per 2 lakh population. Important indicator is ARI. Don't confuse with the malaria API. Annual rate of infection means every year how many new individuals are having infection. Because if a 1% ARI is there, in future there is a possibility they will develop into an active disease, and that number predicted is around the 50 sputum positive cases per 1 lakh population. Okay? 50 sputum cases per 1 lakh population. Then extra HbA 4S screening symptoms we already talked about. Then this is again important point is that in our program now we are doing both X-ray and sputum together, but preference is given to the sputum smear examination, and before start of the treatment we are having the compulsory CB NAT in every patient. Okay, and we had already talked about this point that HIV patient maybe we are not wasting our sputum sample and directly go with the CB NAT. Okay, so CB NAT is the first investigation of the choice of diagnosis for the tuberculosis in HIV patients. Okay, then now we can be starting the ATT treatment based on the clinical ground also. Okay, even अगर sputum smear negative है, X-ray negative है, CB NAT negative है, symptoms अगर हैं तो you can give the trial and diagnose this patient as a clinical TB. Children में अगर sample available है sputum smear, again you don't waste your sample because it is difficult for a baby to give the sputum. In a sputum smear, directly go for CB NAT in a child also. Okay. So this is about the diagnosis. Then yes, these are the 3-4 terms we should be knowing. The new case means who had never received the ATT in the past or has taken ATT for less than 1 month. अगर previously treated मतलब who has taken ATT for more than 1 month. What is the end result? If it is completely cured, okay, but if it is completely cured and after that having again the symptoms, so it is a relapse case, means previously treated, now having again the symptoms of the tuberculosis. Treatment failure means taking the treatment but sputum is again becoming positive after the negative smear, or even after 5 months the sputum is still positive. They are the failure, means they are not responding to the drugs, and if patient has not coming for the follow up, who has taken the ATT for more than 1 month but not coming for the follow up, it means it is the defaulter cases or the treatment after loss to follow up. The cured means taken the full course of APDD and at the end the last 2 smear are negative. Treatment completed matlab taken the full course of ATT but we don't know the last 2 sputum samples. Okay? So this is some definitions, it is important and try to remember. This is the BPAL-M regime, the drugs and their doses, try to remember, and this is the eligibility criteria for use of BPAL-M regime. Now, Nikshay Mitra is another activity that government is promoting to adopt the tuberculosis patient for the proper care, and this adoption can be done either at a corporate level or the organization level or at the individual level. Now, we are also giving incentive to the DOTS agents who are giving the medicine. Now, for the completion of the drug sensitive TB, it is 1000 rupees to the DOTS agent. Completion of MDR or XDR total 5000 rupees, but in the 2 segments, the 2000 after the intensive phase and 3000 after the continuation phase. So don't confuse this about from the Matru Vandana Yojana. मातृ वंदना में भी टोटल 5000 था, बट उसका जो स्लॉट था 3000 एंड 2000 था. यहाँ पे अपोजिट है 2000 एंड 3000 है. सो दिस इज ऑल अबाउट अवर ट्यूबरक्लोसिस. Now, COVID disease is gone. So, the no question we had seen is being asked for the last 2 years. Means till 2023 they had asked the questions from that, but it's still just a quick recap. The best test for the diagnosis is it is RT-PCR test, and the most common mode of transmission was through the droplets. And in high risk cases, we tried to test the asymptomatic individuals also, and who were considered at high risk, who stayed at a distance of less than 3 feet for more than 6 hours. They were the high risk cases. We had the different categories of the patient based on their respiratory rate and SpO2 level. The special COVID care centers for mild and very mild cases, dedicated COVID health centers for moderate cases, and dedicated COVID hospitals with the ICU facilities for the severe cases. How to prevent? Just remember this, that personal protection may we have to use the N99 mask. Wash your hands with soap and water for minimum 20 seconds. 70% alcohol is used, is content in the all hand sanitizers. These are all the PYQs. Then we are having all the type of COVID vaccines available in the market. Then we were mopping the surface or spraying the disinfectant on the articles with, and that is containing the 1% sodium hypochlorite as a disinfecting agents, and the distance of 6 feet was recommended. India में no autopsy has been permitted till now. All the vaccines we are having, but 2 vaccines which has been used very commonly in India is Covishield and Covaxin. Covaxin is indigenously developed in India, and Covaxin is a killed vaccine and Covishield is viral vector vaccine. Now, both had been recommended as the primary doses. Now, Covishield was given in children, individuals more than 18 years, but more than 15 Covaxin was advised. Both the vaccines were stored at +2 to +8 degrees centigrade, and the 2 doses at a minimum gap of given as the 4 weeks we were giving. Later on the gap was increased. Now, the vaccine which were stored at minus temperature, and this is the Moderna and Pfizer-BioNTech, which were recommended to be stored at minus temperature. And these are the mRNA vaccines. The vaccines what we had developed as a booster doses is Corbevax, which was used as a booster doses, and the Covovax. This was also used as the booster doses. Corbevax we had given to the 12 plus children also, because the last vaccine we had given is 12 plus children, and 5 plus we were planning to give, but it was not needed because disease disappeared. So, Corbevax we had given to 12 plus as well as a booster 18 plus age mein. The Covovax was recommended as a booster 18 plus age mein. Then we had also developed a booster dose as through the nasal route, and that is Incovac. So, the vaccine which is COVID vaccine which is given by the nasal route is the Incovac. Okay? Try to remember the strain of these 2 vaccines. Covishield is chimpanzee adenovirus CHADOX1N COVID-19, that is COVID-19, and the Covaxin is the NIV, National Institute of Virology, Pune, NIV 2020 year, and the number is 770. Okay. Now, facts are that once a person had received the immunoglobulin, we have to give the vaccine after 12 weeks, or if had a natural infection, we have to give the vaccine after 12 weeks, means active and passive immunity we are not giving together in COVID. Monkeypox mein, this was another condition which has from the same family virus was as the smallpox, having the rashes similar to the smallpox, having the pleomorphic rashes is centrifugal arrangements. Okay? They were mainly on the peripheral part of the body, and their secretions were containing plenty of the viruses, and when these blisters they rupture, the ulcers are formed and their crust is also containing the viruses, and that's why the period of isolation was from the period of isolation for this monkeypox was the 2 days before the rash till the complete removal of the scab, and that was taking roughly around the 3 weeks time. Okay, that was the differences from the chicken pox. Gismic crust is not infective, and the mode of transmission is mainly coming in direct contact of the secretions from these lesions or the rashes. Now coming to the non-communicable group of the diseases. Obesity may we should be knowing the indexes. The most important WHO obesity index is Quetelet index or BMI, calculated as weight in kilograms divided by height in meters square. The cutoff for obesity is if a BMI is 30 or above, it is called as obesity. Now, when we can say it's a morbid obesity, morbid means when BMI is 40 or more, it is morbid obesity. Then based on the percentile, if weight is between 5th to 85th percentile, we say it is normal. But if it is between 85th to 95th percentile, it is overweight. And if it is more than 95th percentile, it is obesity. When we can say it's undernutrition, when the BMI is less than 18.5, it is undernutrition. So 30 or above, it is obesity, less than 18.5, it is undernutrition. Other indexes are the Pondral index, which is used for calculating in children. So it is measured as the weight in grams divided by length in a centimeter cube into 100, just correct it. So it is a weight in grams divided by length in a centimeter cube into 100, that is what is the Pondral index. Okay. The Broca's index is, it is the ideal weight is your height minus 100. Height in centimeters minus 100 is your ideal weight, and if it is more than that, then you are obese. Then Copless index is a ratio of your actual weight to the ideal weight. Okay, and if it is less than 1.2, you are normal, and if it is more than 1.2, you are having obesity. So these are the other indexes. So try to remember their name and details about the Quetelet index or BMI. Now the height and weight, if you don't know, then still with the weight height ratio you can have an idea of obesity. Waist height ratio, waist hip ratio, not the height, it's a waist hip ratio. If it is more than 0.9 in male and more than 0.85 in the female, it is suggestive of obesity. You can measure the skin fold thickness with the Huppenden skin caliper, and the most important site is mid triceps. Okay, and mid triceps, where if it is more than 32 millimeter in the female and more than 18 millimeter in the male, it is considered as obesity. Now waist height ratio indirectly gives you the risk of cardiovascular diseases. Agar waist height ratio आपका more than 0.5 है, you are having a high risk of cardiovascular diseases. Now cardiovascular diseases में the three phenomena are very important. One is the step approach. Step approach is, this is an image, we have to investigate the stepwise, and this is used for surveillance of non-communicable diseases. Means first you have to look for the personal habits, then the physical parameters like a height hai, weight hai, or skin fold thickness hai, waist hip ratio or the waist height ratio, and then go with some biochemical parameters. Now tracking phenomena is for blood pressure. Means if you track a person and record their blood pressure, the children who are having the blood pressure towards the lower side in childhood, they had a blood pressure towards the lower side in adults, and those who are having a blood pressure towards the higher side in childhood, they are having a blood pressure towards the higher side in adults. Okay, so this is your tracking phenomena. So this could be your image based question, and this is related to blood pressure. Then rule of half is again related to hypertension. Means half of the total community is hypertensive. Those who are hypertensive, half of them are diagnosed. Those who are diagnosed, half of them only are on treatment, and those who are taking the treatment, only half of them had a good control of blood pressure. So this is what is the rule of half, and it is for hypertension. Very important famous study we had conducted is The Framingham Heart Study, it was a prospective cohort study to know the dietary risk factors of cardiovascular disease, and based on that we had drawn planned a diet that is called as a prudent diet or the cardioprotective diet, and total energy from the fat should be only up to 30%, 10 to 30%. It is the WHO guideline, but Indian guideline says it is only up to 10 to 20%. Saturated fat energy contribution should be less than 7%. Unsaturated fat should be 6 to 10%. Trans fat should be less than 1%. And salt intake should be less than 5 gram per day, and daily cholesterol intake, it should be less than 300 milligram per day, or roughly if we talk about the calories, it should be less than 100 milligram per 1000 kilocalories intake. Okay. If we talk about the cancers, the most common cancer in the world, it is the breast cancer. The most common cancer in the male overall, it is the lung cancer, but the most common cancer in the Indian male, it is oral cancers, and the most common cancer in occupation, it is the skin cancer, and most common cancer in the rural females in India, it is cervix cancer. We talk about the blindness. The cutoff level of blindness is vision less than 3/60 in the better eye with best possible correction. Most common cause of blindness in the children is the vitamin A deficiency, and in all the age group it is cataract. We should be knowing the categories of the blindness because question is asked and we have to identify in which category the person is. So, look for the vision in both right and left eye, and which is having the lowest vision and which is having the highest vision. So, जो highest vision है in which eye, the better eye में you have to look for the vision, and then you decide the level of the or category of blindness. Now, old classification is different from the new one because in old में we had a cutoff at less than 6/60. So, any person having a vision less than 60 was called as a blindness, but if a vision was less than 6/60 to 3/60, it is economic, not able to go to the job. Okay. If it is less than 3/60 to 1/60, not able to move in a society alone, so social blindness. Agar less than 1/60 to perception of the light, it is difficult to move in house and it is manifest blindness, and no perception is absolute blindness. But now as per the new protocol, the cutoff has shifted to the less than 3/60. So, now below the 3/60, everyone it is the blindness, and the normal vision or no impairment we call as a vision up to 6/18. Okay. So, in old classification between the 6/18 to 6/60 we had a one slot that was called as a low vision, but in new classification we called this as a visual impairment and we had a two slots. The low vision parallel to the mild visual impairment and the economic blindness parallel to the severe visual impairment. Okay. Now, our vision was to avoid the preventable causes of the blindness by 2020, and this is the global vision, and we had included the diseases which are happening or seen in that particular zone or country causing the blindness. So, the diseases globally which has been included under this program of Vision 2020 and India, it is the 4 diseases are common like cataract, refractory errors, childhood blindness and the trachoma. But the disease which is not included in the Indian scenario, it is onchocerciasis because it is not seen in the India. The diseases which are included in the Indian scenario is glaucoma, the diabetic retinopathy and corneal diseases. Okay? So, sometimes the question is asked that all are diseases included under the Indian scenario except and the global scenario except. Okay? Then to overcome this preventable cause of blindness and to give the services, we had developed the special infrastructures, and 2 very important infrastructures are there. The one is the base level, that is a primary vision center or the vision center covering the 50,000 population, and there the paramedical ophthalmic assistant was present, not the ophthalmologist. Paramedical ophthalmic assistant was present, and if you can remember, this is the same vision center where when we were doing the eye checkup of our children in the school and they were found to have the vision less than 6/9, they were referred to these centers for correction. Then we are having the secondary vision center or the service centers which is 5 lakh population pair, and it is having the ophthalmologist. So, not every CSC it is having ophthalmologist, only the upgraded CSC which is covering a large population, and every district hospital we are having ophthalmologist are there. So, this is about our blindness. Now, if we talk about some extra edge in the diseases, that sickle cell anemia our mission is to eliminate the sickle cell disease as a public health problem before 2047. Okay. Then for prevention and control of the snake bite and venoming, that is to halve the number of the deaths and the cases of the disabilities because of snake bite by 2030. So half of the deaths करना है हमें, और जो disabilities हो रही हैं उसको half करना है. Then about the suicide program, that we have to reduce the suicide mortality by 10% by 2030, and there is an app to track availability of the anti-rabies vaccine and anti-snake venom, that is Zuvin app. जैसे Covin app है for the COVID, then we had Uvin app है for the UIP vaccination beneficiaries. This is a Zuvin app related to zoo means animals. Now, coming to our last topic of discussion is some logos of health related activities. Indian Newborn Action Plan, this is the logo, and the goal is to bring down the single digit neonatal mortality and stillbirth by 2030. Another important is National Program for Prevention and Control of Non-Communicable Diseases, and here the aim was that we will be screening now 30 plus. This is the first point. Earlier age was 40 plus, but now we started screening 30 plus for blood pressure and the diabetes, as well as then we are doing the screening for blood pressure and diabetes in every pregnant patient also, and this is started from sub center because we are having a BP instrument, so we can measure the blood pressure. So hypertension can be detected and blood sugar can be detected at sub center, so we can diagnose diabetes also. Then Ayushman Bharat program is a very important program. This is the logo. 5 leaves means a 5 lakh of the support is given per family per year for medical facilities. The two programs were merged in this program, that is a school health program and health and wellness centers. Okay, so health and wellness centers, those centers which are giving the primary level care, now it is called as Ayushman Arogya Mandirs. So till the PSCs primary level care which is given in rural and urban areas, now they are called as Ayushman Arogya Mandirs. Now 3 words: Ujwala, Ujwala, Ujwala. Ujwala is prevention of human trafficking. Ujwala, it is giving the free LPG connections to avoid indoor air pollution. Ujala means LED bulbs availability at an affordable cost. Then we are having another program as the Kaya Kalp. Kaya Kalp is जैसे किसी को बदल देना. It is to maintain the cleanliness in the public sector, and this could be your image based question. The logo of this program like a पेड़ की तरह से है, and here we are giving the award to the public health services based on the ranking. We do the ranking and जो first rankers है, we are giving the cash awards. Urban Heart, it is a urban health equity assessment and response tool, means in urban areas the services are available equally to all. Then we are having JEET, that is a joint efforts to eliminate tuberculosis between the private and public sector. This is again the medication or the medicine event reminder monitor. This is another new box which is coming up for the drug compliance, that instead of now, earlier we were sending the missed call on toll free number. Now this is a digital box connected with the Bluetooth device, and if a patient is not opening the box till a particular time, it will give you the reminder, and once you open the box and take out the tablet, automatically it is registered on the Niksha portal. So it is again a medication event reminder monitor. Then we are having the SARS activity, it is related to respiration. So social awareness and action plan to neutralize pneumonia successfully. Monica project is monitoring of cardiovascular disease or cardiovascular accidents events are there. Leprosy is a musket, and this is for Sapna is a musket for leprosy awareness, and there is another musket given by UNICEF is the MENA, and it is related for the child empowerment. ठीक है, child empowerment के लिए था. Then 3 words: Nikusht, Nikshay and Nishchay. Nikusht is the software for leprosy. Nishchay we discussed is a UPT kit, and the Nikshay, it is the tuberculosis software. ठीक है. Anmol is A&M online, means providing the tablets to the A&M workers and for the quick entering of the data and analysis. Then Sneh Shivir, these are the organizations which are working for the children and women. Sarthi van, it is a mobile van for family planning promotion. And Telemanas, it is mental health related, so it's a teleservices we are giving regarding the mental health all over the country. So free tele mental health services are given throughout the country. And जो nodal center है, इसका nodal center is the Nimhans है, that is situated in Delhi. Okay, so toll free number जो है helpline number 14416 है. So any person having some mental health issue or mental health related issue, they can just dial this number, and expert is sitting and they will be helping you. There is another portal like MCization. It is a portal for promotion of quit tobacco movement. Okay, then Jai Vigyan, this was a program started for understanding of rheumatic heart fever and rheumatic heart disease. And this is about the various amount of incentives we are giving to our ASHA workers for various activities. Like ASHA, they are not having any fixed salary, they are having the incentives. Whatever the work they are doing, they are getting the incentive. And there is an update here that the minimum incentive which has been fixed by the government, minimum incentive is fixed by the government for the ASHA is 3500 rupees per month. 3500 rupees per month, because could be a possibility that there is no delivery, no work in that area. So what they are going to get? So the government has said, okay, you will be getting the minimum incentive of 3500 rupees, and uske baad mein whatever you do an extra work, that means total आपने जितना काम किया है उसके अगर ऊपर जाता है beyond, so you'll be getting in that extra amount. अगर उसके नीचे आता है, like suppose a 1 month incentive of ASHA is only the 1000 rupees, but still she is getting 3500. और अगर 1 month incentive of ASHA is 10,000, so she will be getting a 10,000. So minimum incentive जो है वो 3500 rupees per month है. So this is all about our the rapid revision of the subject. And in the last, I can only say that no need to worry, beta. I know that you can do it. You are doing best on your part. Just go and doing like this only. The few days are left. Don't be distracted. Don't allow the negativity to fall on you. Just believe in your hard work. Be positive. Have faith in God. And I'm very sure that you all will pass with flying colors. So, all the best.